Thank you. Good morning, members. Welcome to the Health Scrutiny Committee today, Tuesday, the 12th of October. We have two guests with us today, and in a couple of minutes, I will introduce them. Can we first of all agree to the minutes from the last meeting on the 7th of September? Does anybody have anything that is of concern to them within the minutes? No, perfect as usual. Thank you, Noel. May we have apologies for absence, please?
Yes, Chairman. We've apologies from councillors Adams and Bailey, and councillors Lee and Eddy are substituting for them. Thank you.
Do we have any from any other group?
I'm ever so sorry. We've had apologies as well from Health Watch as well.
So Health Watch aren't with us today?
No, they've assured us they'll be here for the next meeting.
Thank you. Thank you. Do we have declarations of interest, please, by members of officers? Disclosable pecuniary, please. Yes, Councillor Barney.
Yeah, just in relation to the mental health discussion we're going to have, I'd like to declare that my wife is a clinical psychotherapist, and she has worked with some of the services in Nottinghamshire, not least Harmless, which is a charity that works for suicide prevention and self-harm. And she's currently working for a school that looked after children. So just like to declare that. I'd also like to declare that my daughter has type 1 diabetes and is a recipient of medical services ongoing within NUH, for which we are most grateful.
Thank you, Councillor Barney. Anybody else, please? Yes. Fine, thank you very much. Councillor Gowland, did you?
I previously said I work closely with NUH maternity services, or at least obstetric services, through my job. I don't think it's a conflict of interest.
Well, we'll have it done. It's always useful. Councillor Lee.
Thank you. I get ongoing help and support from Nottinghamshire City Council due to my prosthetic leg and ongoing appointments there.
Thank you. Councillor Eddy.
I have checked, but I'm a director of a mental health charity called Head High, and my husband is a community staff nurse.
Thank you very much. And I myself have a daughter who works not in the maternity department at NUH, but she certainly works at NUH. So I will give that as an interest too. Thank you. Well, I think we've nearly all declared an interest. So I think we can move on now to, now we have got a change in the agenda. I am bringing the two Nottingham University Hospital agenda items forward, and we'll go back to Bassett Law and the mental health issue afterwards. So we have this morning with us, unfortunately, Dr. Keith Girling, who is the medical director, apparently is ill. So he is unable to be with us today. But we do have Michelle Rhodes. Good morning, Michelle, who's the chief nurse of NUH, and I'm sure can answer our questions. If not, we'll have to have Dr. Keith Girling answer them in the future. And we also have Rosa Waddingham, who is the chief nurse for Nottingham and Nottinghamshire CCG. So we will move on, and I will ask you, Michelle, I'm sure you've got a report to give us on the state of NUH, please.
Thank you very much. And sincere apologies from Dr. Girling and from Sharon Wallace, who's our Director of Midwifery, who is at an inquest this morning, so is not able to join us. She would have wanted to be here as well. So I have submitted, as part of our report, some graphs to you, which I'd like to not go through one by one, if that's okay. I'd like to pick up on two of them in particular, if that's okay with you all. So if you look to the last
the copy.
Has everybody got it? So So you're obviously all aware, and I've been here and spoken to you before, that from our CQC report last year, we developed an improvement plan for our maternity services at NUH. There are a number of items that are contained in the maternity plan, and one of the things we talked about before was the indicators that we will use to measure our successes going forward. So there are an awful lot of indicators that we use, and we collect information from a national perspective and a local perspective. But these 14 that are on this slide are our bellwether indicators. So they are the ones that are our sort of most significant indicators that we're collecting information on now. And the slides that are contained within the pack about birthing, section rates and turnover rates are all part of the bellwether indicators. So I'm not going to talk to each slide individually. I'm happy to take questions on any of those. So those 14 indicators are there and available to us now to talk to you about. The two bits that I wanted to really focus on is the positives for the maternity services since we last met, and then what our biggest risks are, if that's okay. So firstly, to say that we've done and we are doing a significant amount of work with Rosa and the CCG, with Health Watch and the MVP about listening to women, and we've implemented a lot of things since we met last time, and I think there's several of them that are worth mentioning today. The first I would say is last week we launched our maternity advice line, which is a 24/7 line where women can have one number, they can contact the one number and they'll get a midwife on the end of that phone to answer any of their questions and queries to them. So it's had excellent feedback so far, obviously only very new in the making, but so far really good feedback from women. Our FFT, so our family and friends test, feedback from women is really good, but we only have quite a low response rate from our ladies. So we have introduced the QR code, like you get for the scan for the NHS app, and that's been posted all over antenatal hospitals and things. So our ladies can just scan to improve the response rate, but our feedback is really good. We have incorporated, both Sharon and I went out to meet the parents of a baby that unfortunately died, and the lady had produced a video on patient safety and duty of candour and the importance of openness and honesty. And I'm happy to say that we're using that video in our training within the hospital at the moment, and the lady herself is coming in to support that, which has been fantastic for us. At our last trust board, we had parents of a baby who had a difficult time come to talk to our public trust board, and they were able to explain their story to the whole of the executive and the trust board, including the chair and the chief exec, and were able to talk through that. And it was really brave of them and a very powerful story for them to tell. We've also, for all of our maternity training, for all our midwife and obstetric training, we're now introducing women's stories at the beginning of all of that. So if people want to come and talk personally, they're able to do that. Otherwise, we have video and written stories from our women and their families. So I hope that gives you a flavour that we are trying to engage much more now with women and their families, with all of those. And we're doing that with support of the CCG and Health Watch. We've had a couple of meetings with Health Watch since we've met last time, which have been really helpful to us. The biggest risk to us at the moment, as far as our improvement plan goes, remains as staffing. So midwifery staffing remains a challenge to us. On a very positive note, we've taken on, or we are taking on now, up to the end of October, 38 additional midwives. They're all newly qualified midwives who are all starting with us. And there is a second cohort in January that qualify in January of about 20 midwives that we're working with now to try and take those midwives as well. The difficulty for us is we still have vacancies, so we're still working on a daily basis with our teams. We have several multidisciplinary team meetings every day to manage staffing across both of the sites. So it remains a risk for us as an organisation with regards to maternity staffing. The second risk for us is staff morale. So you all obviously have seen that we've had our recent CQC report on well-led, and that's had a significant impact on the staff in our hospital, including the maternity staff. So we're working really hard with our maternity teams and the whole organisation to rebuild some of the trust that we've clearly lost over whatever period of time it's been. So we do have staff that are exhausted because of the last 2 years and also are feeling really low at the moment because things at NUH aren't as great as we would like them to be. So we're doing a lot of work with them. For maternity in particular, we've got counselling services specific for our staff, and we've got a full-time counsellor who's very well used in that department. Staff can self-refer or be referred to her, and we're getting a second one. We'd hope to have two, but the other lady didn't come, so we've got to get a second one as well, and we're extending that service out across the rest of the hospital to some of our other areas as well. I think the other big pieces of work that we're doing at the moment are really with regard to renewing some of our pathways and our policies. So that's what I'd say, Councillor. I wasn't going to do a
And thank you very much for attending. And I must say I'm extremely disappointed that Dr. Keith Girling isn't here, because there's a number of issues that I wanted to raise personally with him, but I wish him a speedy recovery.
Thank you.
Obviously. I'd also like to say that on behalf of the committee, as the first speaker, that we take our responsibility to scrutinise the health services of Nottinghamshire extremely seriously, and we're now embedded as a committee, and we're getting to grips with this ongoing issue of maternity services at NUH. I'd like to kick off by thanking the Trust for the very warm welcome that I received at the City Hospital back on the 22nd of September. And I know that the other committee members are looking forward to visiting both the City and the QMC, and of course the very important midwifery services, community midwifery services, which operate across Nottinghamshire in the coming weeks. And you mentioned Sharon Wallace. Again, we're sorry she's not here today, but we completely understand why. But I'd like to tell the committee that I had the pleasure of meeting Sharon Wallace, the new Director of Midwifery Services for NUH, and I had a good amount of time with her. And I was very encouraged by her strong pledge to see the job through. She looked into my eyes and promised me that she was going to stay in position for at least 3 years. And she shared with me that she thought it would take that long to get the Trust services back to where they once were as this centre of excellence that we all looked up to in Nottinghamshire for the training that's provided by the NUH services. So we hold her to that, and we look forward to welcoming her at future committees. Most of all, though, from the visit that I've had, I would like to personally and sincerely thank the staff that I met on the shop floor, the doctors, the nurses, the midwives. I met lots and lots of staff. I was there for several hours, and I was absolutely astonished by their candour, by their strength of character, by their professionalism, and by their honesty. Despite my chaperone's best attempts, they did not hold back in wanting to communicate with me. And I'm very, very keen to get other members of the committee to also go and visit the services, because I know that you'll get the same response. And despite the exhaustion, and yes, I sensed exhaustion, the commitment from the people that I spoke to, many of them, was absolutely there. Not about getting more wages, not about just to get the service back to where it should be so they could believe in it and deliver the best service for the mothers and the families of Nottinghamshire. but we have a duty to scrutinise. And I have a number of issues that I feel I would like to raise this morning. And I have to say, it brings me absolutely no joy in doing so. Since we last met and had the maternity services at this committee, we're all aware of the national media scrutiny that has been added to the pressure of the scrutiny already under from all of the CQC reports. And we've watched those parents, the brave parents that have gone on national television and talk of their experiences. And I suspect there's not one of us that hasn't been moved to tears hearing those accounts. And of course, we're also aware of the number of parents that haven't had the strength to do that, and who can blame them? And for that reason, I want to ask some questions, first of all, about some of the literature that we've been sent and provided with, which we thank you for. But then also I'd like to relay to the committee a couple of the experiences that I picked up on from my visit. So if you'd give me the time and the liberty to do that, Chair, I'd greatly appreciate it.
Certainly.
So in the documentation provided, and I wanted Dr. Girling here because I wanted to look him in the eye and ask him, you talk of a full maternity improvement action plan, and yet where is it? When will it be available to us? When will it be disseminated to all staff? I've asked staff on the shop floor if they have seen the plan. They haven't. Where is it? And Dr. Girling, in your absence, I ask you, where is the full maternity improvement action plan? This committee needs to see it. You tell us about the maternity dashboard that uses recognised maternity metrics. I ask, well, what are these metrics? When can the committee see the dashboard? When will it be embedded with all frontline staff? The NHS CCG maternity briefing note that we've all been provided with damningly states, in its own words, despite considerable work to develop a meaningful improvement plan and provide a maternity dashboard, there is not clear triangulation between these or the challenges the service face. Not good words from your own reports. And all these months in, we remain concerned. On my visit, I also had a number of comments about the state of general IT within the maternity services. And I heard real concerns about general usability and cross-interfacing of systems used by the daily medical staff. And so I asked the question on their behalf to the leaders of NUH. Does there not need to be a commitment to a single digital record, easily accessible to all staff, that incorporates System 1, that's the primary care access software used across NHS, Medway, and the woman's handheld record? Michelle, you mentioned this morning, and I just pick up on this, the maternity advice line. Fantastic that that's been taken on board. But I'd like to ask, what grade of midwife is staffing that line? Is it a senior midwife, or is it one of the new recruits? I have a concern that it might be some of the junior staff. So getting more down, if you allow me to continue, Chair.
Please continue.
Are you sure?
Yes.
Getting down to my visit, I was shown a couple of items, which again I was encouraged by, which have been implemented on the wards as a direct response to the CQC report and the downgrading. And one of these concerned triage and the triage escalation procedure. And I sensed that the staff were very keen to show me that. It's a very simple document, and I don't criticise it for its simplicity. I like simple. And it's fantastic, as I say, to see that this has now been implemented. So the triage escalation procedure, I'll take a moment to explain. For mothers that arrive at the hospital at any point between conception to birth with an issue, they're obviously put in a queue to be assessed, to be considered where they need to go in the hospital and what needs to be done. That's the triage element to that. And before the CQC report, I understand that there was no escalation procedure in place to manage that queue as numbers grew and got more and more unmanageable from 0 to however many. So the escalation procedure, which I was shown, is a simple A4 piece of paper like so, that has 3 columns on it. I think it started green through to yellow through to purple. Green being less than 5 people in the queue waiting to be seen, yellow being less than 8, and purple being 10, which effectively is pretty serious. And the escalation chart details what staff should do at each level to take a remedial and emergency action to manage that situation appropriately, basically pulling a staff in from other areas. It's really good. It's there, and it's been implemented because of the CQC report. However, I asked a simple question: what happens if you have more than 10? And I was astonished by the answer. It came back, well, we go into Purple Plus. Purple Plus, I said. Purple Plus, yes, it's a system that the staff themselves have and a phrase they use for when that situation arises and what they then do. This is really serious at that point, a moment in time. So I asked the next obvious question, how often are you experiencing Purple Plus? To which I was told about every 8 to 15 days. I got the impression that this was serious and mattered, and I felt the staff were keen to communicate this to me. And that's why I've taken the time to share it with the committee, that every 8 to 15 days, the queue is at such a point that the staff are concerned about how they remedy that action and that situation. I asked the staff as well on the back of that what they felt could be done. Was it simply a matter of more staff to improve that triage situation? And they told me that there had been a plan that's been talked about for many years, but yet to be implemented, to split out the triage services with the general patient care, the initial stages of care that take place. I asked why that hadn't happened, and I was told they didn't know. So I would like to put to the board, is that something that should happen on their behalf? I asked that question, when can that be actioned? Also, another aspect was listening to mothers. The CQC report highlighted that mothers did not always have the opportunity to share their thoughts and experiences. And again, I was encouraged to see that there are now measures in place to ensure that is happening. However, I was somewhat startled as a father of 4, and having watched my own wife produce 4 children very nobly and breastfeed all 4 of those children, that the simple thing that appeared to have been instigated more than anything else from those responses was a request for more food for mothers as they begin the breastfeeding process. So a snack trolley, I was told, has now been implemented for biscuits and snacks to be made available to mothers. Fantastic. But my goodness, how first principle? I was astonished that only now does that seem to have been put in place as a result of the CQC report. And again, not to be overly critical, these are welcome things. I just want to mention also that I picked up on the culture of bullying and intimidation, which also runs through the reports, and I don't believe it's been dealt with, and I believe it could be quite simply. On staffing, and I am concluding, Chair, it's wonderful that you've recruited 30 new staff, 36 new staff, 38, however, the number seems to change, and I hope that I believe they'll be in place by the end of November. I realise that this is still a huge gap from the numbers that we were presented at the last committee, where I think it was over 80 staff that were required. But nevertheless, we know there's a national midwife crisis of people coming through the system, and so we applaud NUH's efforts in bringing those staff onto line. However, again, from my presence and time on the ward, it was very clear to me that the biggest issue faced is not the new staff coming in, but staff leaving. And I was told over and over again, the words retention, retention, retention reminded me of Tony Blair. That is where the staff were telling me the trust need to focus more acutely than anywhere else. Senior level 6 midwives are leaving the service in droves because they are exhausted. They need to be retained. And surely now more than ever at this time, with all these new fledgling recruits coming in, their mature experience over many decades is more vital, more needed than at any other point. So I would like to raise that as a point. How do we retain the staff? How do we get them back? I was also concerned, although I don't have enough detail to know whether that concern is justified, at the number of level 6 staff which appear to have recently been moved from their position on the wards, actually delivering and helping and at all stages in the pregnancy cycle, being taken up to management positions. Again, that's left a girth. Would it not be better as a temporary measure to get those staff back, pay them the same money, but get them back on the shop floor where they can make a real difference? I felt that that's what I was being told, and I would like to communicate that to this committee. So there are grounds to be positive, with yet the appointment of another director of service, and I was pleased to meet her. I also was encouraged that the buildings seemed to be in very good order, and I'd not visited my son. My eldest son's 21 this weekend. It's 21 years since I last visited when that facility was new for his birth, and the buildings still look in great shape. However, and I conclude, following the initial CQC report about maternity services, the subsequent reports that we've received, and the national media scrutiny that we've all experienced and know is going on, and on the back of what has now been presented to us as this damning and unequivocal CQC report about the state of not only the maternity services, but the entirety of NUH, that downgrades the director-led services to inadequate, I'd like to ask the question, and if Dr. Girling was here, I'd like to have asked him personally, do the leadership of NUH have the ability, and more importantly, the credibility to get this house in order? I don't think they do. Thank you, Chair.
Thank you, Vice Chairman. I gave Vice Chairman a little bit of extra time because I knew perfectly well he had some very good points to raise, which I think the rest of the committee will appreciate. Michelle, would you like to make any answers to that?
I would, thank you. Can I firstly thank the councillor for his kind words at the beginning around the staff and what people are doing at the moment. And I'm going to focus to start off with on the maternity service, because actually this is what we came here to talk about today. So we'll focus on that. And I'm happy to answer the question about the leadership at the end. I'm happy to do that. But first on the maternity services, I'm actually the senior responsible officer on the trust board for maternity, so it doesn't need Dr. Gerlin to answer these questions. If it was a medical question, absolutely. But as the senior responsible officer, I'm perfectly happy to answer as many as I can. So thank you for that. With regards to the maternity action plan, the action plan has been rewritten because the first one was too wordy. Staff weren't involved, weren't engaged with it. So now it has been rewritten, and I'll get that sent over to you, Martin, this afternoon. It is absolutely available. It's been through all our governance processes now. We have a monthly assurance committee where we have the CQC, the CCG, NHSE and I and others, and that is we are held to account for that every month, and that was on Friday afternoon. So I'll get that sent over to you today so you can have a look at that, Chair and Councillor. As part of that, the Councillor asked about our indicators and our dashboard. Part of the pack that you have today is clearly the dashboard. So each one of those indicators are, as I described to you on the slide that says bellwether indicators, they are our top 14 indicators that will be measured on. The bit that you don't have in here at the moment, because we've struggled to get, because not every organisation reports these, is a comparison against the national. So that's the bit that we're working on at the moment, and we will send that over to you. But we're happy to share the wider indicators, the dashboard with you. That does go through the trust's public trust board, so is available in the papers of the trust board as well, in a smaller version, because the actual indicators, there's about 100 of them. But any councillor or any of you committee members want to see that, happy to share that with you. But I hoped that what I'd shared with you today was just as the start of that, so you can see the top 14 that are there. I think the digital, I'm just going to go down, I wrote them all down, councillor, so I'll just go down them all. The digital one is really interesting because we had some feedback. We've invested in a whole host of additional equipment for our community midwives in particular, and when we did that, bear in mind, I started at the Trust on the 1st of June, but when we did that in January, the midwives were having to do more work, which is something that as a Trust we hadn't picked up. So we implemented new equipment, which meant instead of having to put it in once, the information, they've had to put it in twice, they've had to put it in 3 times. So we've had to roll all of that back now to look at the digital equipment. And only in the last week, we've had really positive feedback from our midwives to say how much improved the maternity digital record is. As far as a whole system approach, the ICS, our Director of Digital Services, who is Andrew Fern, is working 2 days a week as part of the ICS team, and we are intending to develop and deliver a digital record across the whole of the community, NUH and Sherwood Forest, so that our women and families can move between and have that record there. That does take a significant amount of time, but it is in the action plan. So once I submit the action plan to you, you'll be able to see the actual individual actions against that. And if you wanted somebody to come and talk to you, particularly about our digital issues, that isn't me. So I'm really happy to get somebody else with expertise to have those conversations with you. With regard to the advice line is staffed by appropriately trained midwives. One of the issues that we have had before is that in our triage unit is that the midwives didn't feel that they were always the best person to be in there. We've stopped that, and Sharon Wallace has stopped that straight away. Our newly qualified midwives don't sit on the advice line unless they have had specific training. They are all midwives midwives with experience. And when we haven't got those, the advice line wouldn't be open. So we would put nobody on the advice line rather than put somebody on the advice line that wasn't able to give that significant advice. The triage document that you're talking about, and our triage and going into purple, we do go into purple. And if I'm honest, Councillor, I'm surprised it's only every 8 to 15 days. I would have thought it would be much more frequently than that, because I have to say it feels like every day in our organisation at the moment. So if you look in the pack that I've submitted to you, there is a regional heat map from the 9th of September, and that puts in all of those hospitals around the East and West Midlands that are in exactly the same or a worse position than us. So what should happen in the ideal world is once you get to a certain extent, you ring round all the other, all of the other hospitals in the region and say who can take our mothers, because we can't take any more. And we've been doing that on a daily basis and nowhere else can take them. So this isn't about us not trying. This is absolutely about the fact that everybody is in the same position as us. And this is putting a considerable stress on our midwives, on our obstetricians and on the other units, as well as our mothers and the families that are coming in. So this is absolutely not through lack of trying. This is because there is nowhere else to send them. And when you look at that, you can see how many of them were closed for their home birth service. Our home birth service isn't closed. We're one of the only ones who are maintaining that service. And you can see how many people were not able to staff their maternity units as they would want to be. So be very clear about this. Our teams, and I'm very passionate about this, are working and doing absolutely everything they can to keep women and babies safe. And this is just what is happening just around the East Midlands and the West Midlands, as well as the whole country. So accepting entirely that the departments do get to a purple level, they do, and I'll be the first to say that. The bit about bullying and changing culture, and I think this comes really to the well-led review, which I'll talk about at the end. I don't agree with the councillor that bullying is a simple thing to sort out. I do agree that as an organisation we need to make sure that we've got very robust processes in place to deal with bullies, and I think that one of the issues that we've had in NUH is that we have listened to people, but we've not always heard what they've got to say. We've not always actioned appropriately what we should have done, and that is to our failing. And we have, as an executive team, apologised on a number of occasions to the staff in the organisation that they feel that they're in that position, and I hold that feel now that we are sorry that staff have absolutely been put in that position. Going forward, we're strengthening our cultural transformation team. We're strengthening all of our policies around holding people to account for bullying. And it's not just about bullying, it's treating each other with kindness and respect, which some of our teams haven't been doing, including all the way up through our organisation. So I don't think there's a quick answer to it. And if the councillor has one, I'm really happy to sit down out of here and listen to it. But we really are trying very hard to deal with that at the moment. I 100% agree with what Councillor Barney talks about around retention. It is equally, if not more important than recruitment at the moment. We have reduced our retention rates and we have reduced our turnover rate, and if you look in the pack, there is a specific, can't find it now, there is a specific measure that shows that our turnover rate of midwives has actually really significantly dropped off. The reason for that is several fold. The biggest reason for that is because when people say that they're looking to leave, or when they hand their notice in, Sharon Wallace, our Director of Midwifery, meets with them personally if they want to do that. Those midwives that have been leaving us, the ones that have recently left, have left in the main because they've had a promotion somewhere else, or they wanted to go into the community or try something different. What we need to do to retain our midwives, as well as our nursing staff and everybody else, is value them, is invest in them, and make sure that we look after them. And that's absolutely what we intend to do going forward. For our midwives, we've started the rotation scheme again. So that was stopped 2 or 3 years ago. I don't know why, which means our midwives do rotate around antenatal, postnatal and the labour suites, and that enables them to have a good experience and be able to support their teams. When that was stopped, it made life difficult for everybody because those staff that hadn't worked on the labour suite for some time felt uncomfortable going down there to help out. So we're reintroducing, or Sharon has reintroduced that again. We've done much more around mandatory training, what we've invested in through Ockenden, which has given us a significant amount of funding for our midwives. We've improved so each nurse gets, when you work out how much it costs to implement a nurse or a midwife, you add on about 21% of the cost of their salary, and that's for sickness, that's for training, and a whole host of annual leave and other things. For maternity, that was only 21%, and what they needed was 26% being able to do all of their training. So we've increased that up to 26% now. Of course, what that means in the short term is we've got more vacancies because we've put more money into the system, so we're creating more posts and we've got more vacancies. But the intention is to ensure that every midwife feels that she's developed or he's developed and is able to stay within the organisation because they want to be here and they choose it as their choice. The last part that the councillor talked about was really around management staff and why aren't they being put on the ward. So we have got a number of specialist midwives. So, for example, and you mentioned this earlier as well, councillor, the breastfeeding midwives. So why can't they go and work on the ward instead of being breastfeeding midwives? Well, they do, but they're very part-time, so they still have to work with mothers around breastfeeding. I think the biggest change that we had was we have a governance team, which of course manages, as you would expect, all the incidents and everything that goes along with that. All of them went back into clinical practice for a period of time, which was great for the ward environment. It was great because there were extra bums on seats, if you like, but actually what that meant was that our delays just shifted. We shifted the bump in the carpet away from making sure that our incidents and our lessons learned were sorted quickly. So those staff have now gone back into their own team. So that, I hope that was all of the maternity questions. With regard to the CQC report, each member of the executive and the trust board has reflected deeply on that report. And I can say this because I've been in post for 6 weeks when the CQC came in. It's been an incredibly difficult time for people. You'll be aware that our chief exec has now stepped down and we have a significant improvement plan in place. Every member of the executive team and the trust board that remains here at NUH is absolutely determined to make this what it should be and what it has been before. But please don't think that this has happened overnight. The issues that are at NUH have been there for some time. We just haven't dealt with them as well as we could have been, and I can honestly say that. So that's where we're at with that, councillor. So I'm happy to say anything else.
Thank you, Michelle. I have a list of people who wish to speak, but I'd like to say one or two things before. Yes, of course. Yes.
So, yeah, just on the bullying, I'm very happy to talk to you outside the meeting, and I'm not willing to talk inside the meeting in a public domain. But I would say that in a primary school situation, everybody knows who the class bully is. And I would say quite simply, ask your staff. They'll tell you where the bullying problems are. And just also on the who's responsible or otherwise, I actually really admire you for coming here. And I can see that you're determined to make rapid and credible change. And I also believe that you're invested for the long term. And Sharon spoke very, very highly of you, Michelle. And I take it very sincerely. But I would just point out that Dr. Keith Girling is Director of Medical Services. He has been involved in this throughout. He's been in situ for many years. And as Director of Medical Services for NUH, I do hold him responsible, as the chairman. These people earn 10 times the salary of a midwife, and they are responsible. Thank you, Chair.
Thank you, Vice Chair. Before I ask people to come in, and I've got a list of names, I'd just like to mention one or two things to you, Michelle. I too am very sorry that Dr. Keith Girling isn't here today. At the end of the day, he has been running this unit for a very long time. Yourself and Sharon have come in, and I'm afraid you're the ones to take the hit on what we say, which is very important, unfortunate, and he would be better here. However, last time the committee detailed the briefing of the staffing, we asked for the details of the staffing levels, which you've given us a little bit of information today, but you clearly didn't give it to the CQC. Some of this information in here really should have been available. Somebody should have got to work and made it available for the CQC, because that report you've had is absolutely devastating to any mother who is going into QMC or City. And I think the responsibility, as Vice Chairman has just said, lies with Dr. Keith Girling, because he has been in charge of the unit and has obviously sat back and let everything happen, and it's not acceptable. Now, last time he was here, we asked how many incidents you'd had, and he said 1. Within 2 weeks of our last meeting regarding maternity, Channel 4 picked the item up, and I know the Vice Chairman and I watched it because we texted each other, and Channel 4 said there had been 15 deaths. Now, last night, I received a text from my Vice Chairman again, because he had the headlines of the West Bridgford Wire. And we learnt from the West Bridgford Wire last night, whether correct or not, I'm going to ask you what is true, that there have been 30 deaths and 46 babies have been born and left permanently brain damaged. Now, could you give us the exact details on this, which is what we asked at the last meeting? We wanted to know. Redact the names by all, we don't want to know the names. We want to know the truth. And we shouldn't have to get our information from the West Bridgford Wire to know what is happening in QMC and City Hospital. It's right that the information comes from you. It's something we cannot get from Dr. Keith Girling. I must say this committee, as an absolute whole, is very concerned about the maternity services at NUH, but particularly its leadership. We, of course, must protect the NUH and City. They belong to the National Health System, and it's a national institution for which we're extremely grateful. The report does not criticise the clinical services. This is the CCG report. It recognises the staff as outstanding, showing care, dignity, compassion, and kindness towards the patients. I recognise there has been staffing problems due to COVID, but the nursing staff, as you have alluded to, are overworked and suffering from sheer be looking to retaining staff right through the maternity services throughout the country. Everybody is short-staffed. You need to keep your staff, because if you don't, they can easily go to Derby, Lincoln, or Leicestershire. It's close enough for them to travel there. Now, to date, we have been hampered by Dr. Keith Girling not giving us the information we have asked for. We've repeatedly asked for it, and we haven't received it. We fully need to understand and appreciate what is going wrong and why, up to date, you have not been making progress. I know the committee feel that they have nothing more than lip service as to your improving services. To date, I'm talking about. Now, I do intend to write to the Secretary of State for Health to inform him of the current state of the maternity unit at NUH and the lack of progress that we've had from the leadership. And I am talking about now, Michelle, before you came in June and Sharon Wallace came recently. I think confidence has been lost, and the Commissioner's report describes a lack of pace and assurance seen across the NUH Maternity Improvement Programme, which you have alluded to, a lack of focus on input and outcomes, that considerable work must be done towards the improvement scheme and the dashboard. You've still got a lot of work to do. And also progress has been hindered by the fact you've had, within 8 months, 4 director midwives and 3 chief nurses. How on earth can an establishment make progress when there is constant change of leadership? So I would ask Keith Girling, if he was Dr. Keith Girling, if he was here, what on earth he's been doing, because you can't afford to let these staff leave. They're precious. We need them, and we need them within the NHS. And a review is going to start, I noticed, on page 82 of our report, and it's going to focus on the changes. You're going to cover complaints, serious incidents, which we cannot get our fingers on, and I hope you truly give me the truth today. Healthcare safety, referrals, concerns and family experiences to ensure the quality and safety of your patients. I would ask Dr. Keith Girling, if he was here, why, when he's been in charge for so long, has he not instigated a review like this before now? Why did it have to come to this head of the CQC giving the most devastating report? No wonder the staff have lost morale. It's a wonder they're still there. But I happen to know that in the report it said how kind they are, how outstanding they work. And thank goodness that was recognised by the CQC, else I think you wouldn't have any staff in the NUH at the moment. Now, I'm led to believe, and it goes along with the incidents, that you've had many, many negligence claims in relation to maternity care over the last 10 years. And this has resulted in £91 million being paid out in damages. My question to you, Michelle, is that true? And I would look how this money could be spent, because if that is true and it's come out of insurance to pay these poor parents out who've had dreadful experiences, then your insurance will increase, your premiums, and that money would have quite ably bought more staff and more equipment, which you need. We're told there was an oversight of the maternity services and the management of performance issues, which hadn't been sufficiently robust, and the issues weren't addressed. And I won't say you, because I really do think, with you, Michelle, and from what I've heard from the Vice Chairman regarding Sharon Wallace, I think there's probably going to be a breath of fresh air, which there well needs to be. There really does need to be. And I think I've met you twice now, and I'm sorry that you've been dropped in at the deep end, because it's an awful end to be dropped in. You want to be dropped in at the shallow end before you find yourself in deep water. But I do find the senior leadership team are actually presiding over a maternity unit in crisis. And it has been rated as requiring improvement. It's a damning report. And I'm afraid I hold, like the Vice Chairman, the previous leadership team fully responsible. We as members are elected every 4 years, and if we don't fulfil our job, we lose it, because the electorate will not vote for us again. With such a department in crisis, I believe that the senior leadership team that were there before you've actually started to pick up and improve should actually stand aside. And I think you should bring somebody in, like yourselves and Sharon, to be in charge with leadership skills, who have compassion, communication, and a desire to make the maternity unit at NUH once again a centre of excellence. And I really feel anybody coming in before June should stand aside and let the new people come in with aspiration, inspiration, and enthusiasm, and bring that unit back to where it always was. And I'm sorry that you've got to stand by this dreadful report. But if you do what you've told us this morning, hopefully you'll pick it up quickly and try and bring this unit back. But as for the former leadership team, I think they should go. I really do. How can new people with aspiration, inspiration and enthusiasm come in and try and move deadwood? I'm afraid you can't. It's like anything else. And that would be my call from the chair this morning. So thank you to both. Thank you for coming. We're not wanting you to take the blame at all, Michelle, but certainly before your time, they need to go.
I thank you for all of those comments, and I'm sorry that you haven't had the information that you need around incidents, and certainly the litigation information is available as well. So I don't know whether it's 90 million or 900 million, to be perfectly honest. I can't tell you, but it will be a significant amount because every hospital in the country has a huge litigation bill around maternity services. It is the highest risk area in any acute hospital, but we have that and it's reported openly, so we can absolutely share that with you. The bits about the deaths and what's been in the West Bridgford Wire or wherever it's reported, they're over different periods of time. So what I suggest we do, instead of me trying to fuddle around it, is I will take that away as an action and pull together what's happened in the last, well, the review that Rosa will probably talk about is going to go back to 2006. So I think that will give us that kind of information that comes from there. But I'm happy for us to look back to 2006 and provide you with whatever information it is that you need, because it is available, including the litigation costs. But I'm sorry, Councillor, Chair, I don't have them in front of me now, but I can get them for you.
That's fine.
The bit about the well-led stuff, and I thank you for your support for myself and for Sharon, and that really is brilliant. We are very passionate about what we do, and I know there's a whole issue here around holding Keith to account, but it would be remiss of me not to say that there is a whole trust board and a whole executive team that's presided over this organisation for a number of years, not just Dr. Gerlin, not just the chief nurse. There is a chief exec, a chair, a number of non-executive directors, as well as there are about 20 people on the trust board. So I feel that this does sound a little bit personal against Dr. Gerlin, and I have to say I find that a little bit unfair.
No, not at all. So, I said the whole leadership team prior to you.
I think that's if that's how the committee feels, then absolutely that should be addressed to our chief exec and chairman of the committee. But Dr. Gerling is clearly part of that, but he's only one member of about 20 people.
No, I referred to the leadership team prior to June.
Yeah, okay.
So it doesn't only involve him, it involves everybody.
Okay.
They've all had a stake, they've all had a say. And clearly it's been wrong, or if they haven't had a say, they haven't done anything, and that's even worse. And it's that leadership prior to you taking over in June that need to look at what they've done or what they've not done, and possibly stand aside for somebody that has more enthusiasm, more communication skills, because that's one of the problems. But I'm going to open it up.
Can I just say before we move on, Chair, just that the last bit for me is, can I just say thank you for recognising what the CQC report did say about caring for our patients, because it was outstanding in spite of the leadership, in spite of what came out in that report. It clearly says outstanding for our nurses, doctors and all of the other team around the patients that's looking after our patients at the moment. So thank you for recognising that.
And anybody who goes into those hospitals does actually comment on a lot of the care that they get. Right, can we just have Councillor John Wilmot, please?
Thank you, Chair, for allowing me to speak on this very touching subject today. Can I first of all say that I'm disappointed, very, very disappointed at Health Watch. Again, this is not the first time or the second time, third time have been unable to be with us. They are a scrutiny organisation that have been heavily involved with the Nottingham University Hospital's NHS Trust maternity service. They've been looking at it extensively. I do know that, but we don't know what's happened. We don't know what they've said. We've no idea, which is a very poor state of affairs when it's such an important issue. Can I welcome this report as I hope a turning point on how maternity services are run at our hospitals. I'm hoping that is going to be the main issue. It's important that the death of a baby on September the 15th, 2019 was not in vain. As the Nottingham University Hospital's website actually states, you fully accept that although our staff are passionate about what they do, we have not created an environment where these same staff can provide a positive and safe experience for every family in their care, every time. As part of this process, I would like to put this question: how many staff have been retrained, and has any staff or management involved in this matter lost their jobs? The September report from the Care Quality Commission makes very stark reading indeed. I do find it disappointing that the visit of the Care Quality Commission in October 2020 was unannounced. The question must be asked whether hospital bosses shared the concerns outlined in the CQC conclusions that declared the service inadequate. I know that the City Hospital and the Queen's Medical Centre are heavily used by residents in my own town of Hucknall. I've got to be honest and say that I haven't heard a bad word uttered by any local Hucknall resident about any staff at the hospitals. In fact, residents tell me the opposite and have nothing but praise for staff at the hospitals. As members will know, one of the main problems highlighted by the CQC was a failure to address a culture of bullying across the organisation, which included cases of racial discrimination. Health bosses were also issued with a warning, ordering them to make improvements around leadership, risk management, governance and culture. Although there is a mention of changing the culture, there is no mention of the bullying nor racial discrimination mentioned by the CQC. I just want to say this is a very, very extremely serious allegation. It's an allegation that needs to be addressed without any doubt, with a special action plan involvement on this issue. Can I also say recruitment? That is the big issue. I know staff leaving is a problem, but the main thing is that you need to sort out the recruitment process. Are you going into sixth form schools, colleges, and all other areas to actually have the opportunity to talk to people about this job? It's a wonderful and purposeful profession. And a good presentation at some of these events would help in the situation. And I'm just wondering if you do any of that. And thank you for letting me speak.
Thank you, Councillor Wilmot. Michelle, would you like to reply to that?
Thank you, Councillor Wilmot, for your questions, and thank you for recognising again that you get good feedback from the residents of Hucknall for our hospitals. I'm really pleased to see that. I think there are two things that we're talking about here. The first is the maternity report and the fact that that was inadequate, and the second is the well-led report and the fact that that's come back as inadequate. The retraining issue in relation to the maternity report, one of the big issues that was picked up in that report was the reading of CTGs, which is the fetal heart monitoring, and the way that midwives, obstetricians and others recognise if that fetal heart is as it should be or not. And the whole of the team have been retrained on that, as well as they've had to take an assessment in regard to that, which is over and above what any other hospital in the country does. So yes, we've done a significant amount of retraining around the issues that were raised in there, including the identification of jaundice babies, which was also an issue. We've also invested lots and lots of thousands of pounds in additional equipment and trained people on that. So I can say, as far as maternity goes, we have done some significant retraining of the teams. I'm not aware of any midwives or obstetricians that have lost their jobs because of that, and I'd be really sad if that was the initial response to any report. The first thing for me is to find out why people have found themselves in that position, and I think we can read through the report the main reasons why they have. So our just culture going forward is about support and redevelopment, and only at that point, if that's not possible, do we then look to see if people need to go and work elsewhere. So not as far as I'm aware, but I will clarify that for you. Recruitment, yes, we do go to schools and colleges. We do lots of work. I think we can do more. You can always do more, but we have done some of that now. And then the important, I mean, it's all important, but the big thing around racial discrimination and bullying is probably one of the saddest things that I've been associated with ever. And I feel that personally as a Nottingham born and bred person who, trained as a nurse in Nottingham, the fact that our staff feel that is very personal to all of us. And we've let people down and openly said that. What we have done since the report came out is a lot of staff engagement events where myself and Keith have presented the report to our teams, and we've asked them to contact us. And I'm afraid to say that we have had over 100 individual staff members that have contacted us to talk to us about their experiences of working at NUH. And although there's a mixture, some people don't recognise what the report says. Far too many people do recognise that there is a culture in NUH that shouldn't be as it is. So we are working with all of those staff at the moment to try and put this right, to make sure we take action whenever we need to.
Thank you, Michelle. Councillor Welsh, please.
Hi, thank you for all the information that you've gave today and everything that you've said, and for everything that Councillor Barney and Councillor Saddington have said as well. I agree with the majority of what they have said. I don't agree with it in its entirety, and I'm going to outline a little bit why that is. So first of all, the starting point is if we start to do a little bit of research of what has and hasn't happened with regards to maternity services, and this is going back to what Councillor Saddington says about those higher up having some responsibility with regards to what happened in 2018. Not CCG actually did do a review of maternity services. They did this with the help of somebody else, and this review was talked about in various board papers in 2018, which have subsequently the only year that have been removed from your website recently, which is interesting to say the least, although I do have them all if anyone wants them. A review conducted in 2018 where the actual results from that maternity review were never published. But if you read that board report, everything that you're saying you're going to do in this independent review is literally carbon copy of what happened in 2018. So why, in 2018, have all those babies and mothers had to suffer the way they have done, because that report was never published and none of us know exactly what happened. So that's my first point. My other point is, Councillor Saddington pointed to the fact that in the West Widgford Wire, they were talking about a number of deaths that had happened quite recently. So again, I looked at some of the NUH's board reports, and I looked at the latest one that is currently published, which has some data with regards to January, February 2021. So maternity-related serious incidents declared in January, February of 2021. The first one is a level 2. It didn't meet the referral criteria to HSIB. I'm assuming everyone knows what HSIB is, but it is a government structure put in by Jeremy Hunt so that it could be referred as an outside body. It was actually someone that dealt with aviation, which was quite interesting, that set up this body. But that's another story for another day. But we have a number of neonatal deaths. We have a maternal death as well. We have, which relates to paragraph 3 of the initial report, which says you're updating on the role of CTG machines on one poor baby's on here. One of the reasons stated is poor CTG contact in second stage. I apologise for my pronunciation of this, so you're probably going to look at me and say she's definitely not medical, but probable bradycardia, which you understand is a low heartbeat. Yeah, so that hits a nerve with me. And I've said this publicly why that hits a nerve with me, because it took 2 machines to find my baby's heartbeat. And I was laying there not knowing whether my baby was alive or not. And I'm sorry if I have to bring these personal aspects into it, but unfortunately I do have to. So that's my second concern. So here we have, if anyone wants the details, they are publicly available at the moment, but be aware that sometimes something's mentioned publicly. Sometimes for some reason they don't appear on the website anymore. So that's my first point. The second point goes back to the fact is this improvement plan is mentioned in this board report of January, February 2021 as being complete and being rolled out, but quite clearly it says they're not attaching it to the board paper. So it's not publicly available. Why isn't it publicly available? So the board paper's there, we can access this, and I hate to talk about this as a piece of paper because I'm also very conscious of the fact, and this upsets me personally as well, as you can see, this is about babies and mothers, you know, so I am really conscious of the fact that I'm not just talking about this as a piece of paper. These are real people that have suffered and continue to suffer. So those are my first points. There are other issues as well as I've looked back across documentation. So I've done a lot of reading on this because what I want to really make sure of is what I'm about to say in a minute is credible and has enough evidence to back what I'm about to say. So in addition to this, there were 35 stillbirths between 2013 and 2016 that were classed as non-serious incidents. That was a decision that NUH made not to class them as serious incidents. Now, I know, and you will probably back this up, that in other areas, if something's a stillbirth, it would usually be classed as a serious incident. And therefore, they have not been investigated. There are women that have left NUH without their baby, that have done everything possible in those 7, 8, 9 months, everything possible. I've left that hospital without thinking it was their fault. This is the reality. This is about talking about real people. So when you talk about what date you're going to go back to with regards to this independent inquiry, it's not long enough, because that 35 stillbirths that have not been investigated in those years. NUH have been contacted with regards to this, and I have seen this, and people have asked, will you be contacting those parents? We don't know. So there will still be mums that out there, maybe they have another child, maybe they haven't. I've spoken to them that couldn't have another child. Couldn't bear the thought of going back in and having another child because she actually thought it was her fault. So this is part of the reality. So in addition to that, I'm not going to talk about SLIs and HLIs. I'll go into that on another issue. But I do think there is an issue. There is systematic failures going on, Councillor Saddington, and this is serious. Systematic failures is what I believe is happening. Okay. Systematic failures. As I said, not CCG, that I've commissioned this so-called independent review, did a review in 2018 and didn't publish the documents. That, to me, is deplorable. It really, really is. And here we are sitting in 2021, and everyone... I don't recall you ever mentioning to any of us that actually we did a review in 2018 and these are some of the outcomes, but actually we just didn't implement any of it. It's beyond. But yeah, there are systematic failures, I believe, with regards to when a child is born and there is a stillbirth or there's a complication of whether it is classed as a serious incident or not. because once it's classed as a serious incident, that triggers a number of things. And there are a lot of babies where they haven't been classed as serious incidents, and therefore there has to be a whole review on those stillbirths that have happened in NUH for a long period of time. That's a massive job, but I believe that has to happen. In addition to this, I'll slightly go off on a slightly different tangent. You talked about a telephone line. You talked about we talk about an independent review that is trying to include parents. The independent review and the maternity line that you talk about is not on one platform of your social media. It's not on your Facebook page. It's not on the NUH maternity page. It's not on the Twitter page. You've not done a press release about it. You haven't said, and women, mothers, there is nothing about it. So when you tell me you're trying to communicate and engage with parents, how? Because it's not happening. It's really, really not happening. And the other thing is, you can't get more public than me with regards to speaking out about my experience. I haven't been asked to be in part of an independent review. No one's contacted me with regards to it. And I'm not saying I'm the be all and end all. Of course I'm not, but I'm actually being quite public about it. So, and the other thing I want to pick up, 2 more points. One point is with regards to the food that Councillor Barney talked about with regards to mothers. I'm going to take it onto a different level. So I would like reassurances that this has changed recently. When a baby is stillborn on a ward at Nottingham Maternity, there is the option to stay with your baby for a period of time, and you try and make that as comfortable as possible for people. I've had fathers that have told me, and this is during the pandemic as well, so you have to bear in mind not many things are open, okay? Have told me that they were hours and hours and hours on that maternity ward for them to have their baby stillborn or something happened straight afterwards. And they were told, we can't feed you. We don't have any food for you, and we don't provide a bed for you. Fathers babies that have just died, have slept on window ledges with their coats over them with no food. Now, I would like to have reassurances that isn't the case, but I've been told by more than one person. That one father was absolutely mortified that hours after his baby had died, he had to go to a drive-through McDonald's and get himself a burger because he was so hungry, but he knew he had to carry on to support his wife. How can we not give him a pre-packed sandwich, a packet of crisps, and a carton of juice? I mean, it's not difficult, is it? It really isn't difficult. So I'm going to go back a bit with regards to systematic failures and with regards to the independent review, and I'll try and be as quickly as possible. On the board, the two commissioning officers of the independent review are former employees of NUH, Grocott and Amanda Sutherland.
Yes, please, Rosa.
Apologies, the independent review of which you're talking about, I'll happily cover in my agenda item, but it has nothing to do with the trust. And in fact, we've not formally notified the trust of any element of that review. And I'll quite happily give some detail to Councillor Welsh and other members on that, either now or in my report. But that is very separate from Michelle, partly for the families and partly so that we can absolutely ensure the independence that we've been so really keen to preserve. So I'm happy to give that update now. Amanda Sullivan and Dr. Nigel Sturrock are not the chairs of the review. They haven't been involved in writing the terms of reference. And as I say, I'm quite happy to give more detail on that when I do my presentation. But that is I must make it really clear that's very separate from the trust.
If possible, then I would like to talk on the independent review, because some of the things that have been fed back to me are slightly different to what you're saying. So I think it would be very good to have that discussion. So if you don't want to talk about the independent review at the moment, I'll cut to the
It'll come next.
Yeah, I'll cut to the chase of where I think I am at the moment. Councillor Sue Saddington did quite clearly say that she thinks that the leadership needs to stand aside.
Former leadership.
Yeah, former leadership needs to kind of stand, and I agree. I agree with that, but I think it needs to go a bit further than that, in the sense that I think these leadership, the leadership needs scrutinising. We need to know why in 2018 there was this review that was never published. We need to know why stillbirths weren't classed as serious incidents and people have to stand up in the court of law with regards to it. We need to know why that's happened. And, you know, with all due respect to this health scrutiny and everything I think we've achieved so far on this maternity services, I think we need some help from a higher level. So my ask of Councillor Sue Saddington and Councillor Barney is that we write a letter to the Secretary of State, but we call for a public inquiry. And I honestly believe that is the only way forward for NUH maternity services. So I've just cited evidence of 2018 where a review was done and yet babies continue to die and we continue to have poor treatment. That we are said today like we're starting from stage one. We're not starting from stage one. People have been known about these systematic failures in maternity services for years and years and years and years. And how long do we have to sit here? I'm not prepared to sit here until, you know, the next election in 4 years' time and say, oh, we had a lot of meetings with them and in the end there was a bit of a change, wasn't there? Because I'm not sure that NUH can change themselves in the way that they're doing it. And I'm not sure, given the fact that the review in 2018 was done by the not CCG, that it's capable of making those changes now. That's my honest opinion as it is. And I believe that we should write to the Secretary of State and we should call for a public inquiry. I think it's high time we had some direct action with regards to this situation, because you know what? I don't want to take another phone call from a mother whose baby has died unnecessarily, not because I don't care, but because it's the most horrendous thing to happen. It's horrendous, and I don't want it to happen anymore. And the only way that I can see out of it, and I've not said all the evidence today, and I willingly share it with other councillors, but I've spent 2 weeks reading documents, a lot of documents perhaps that you've not necessarily seen, because there are so many. I can't tell you how many board reports I've wrote where they've said they're looking to improve maternity services. It's in every single one, dating back to pre-2010. And enough is enough, as far as I'm concerned. And this is a direct plea, actually, Councillor Sue Saddington, that as a committee as a whole, we write a letter to the Secretary of State. And actually, I think we need to visit the Secretary of State and have an appointment with him, because this cannot go on. Thank you.
Can I just come in there before anybody else, because I know the Vice Chairman wants to come back. Councillor Welsh, I fully concur with your thoughts. We cannot sit here for any longer and see this maternity unit falling apart around us. The babies that are born that are injured or die are somebody's precious child that they probably can't have anymore. And we cannot sit here as the Health Scrutiny Committee, as I said before in my own briefing, we cannot let this continue. We will write to the Secretary of State and may well ask that we see him. I have no objection to that. It has to be taken to the highest level. Otherwise, we're looking like a load of Muppets sitting here just listening to what is being said. We have to take it further. It's our right to take it further, and we owe it to the people of Nottinghamshire. And as I made very clearly in my speech, although Michelle might not have quite understood, I'm not being rude, I'm just saying you must have misheard. It isn't you. It isn't Sharon. It is the people who went before you, whoever they are. But we know Dr. Keith Girling because we know his name, but he's not there working on his own. He's got a board behind him. And for the board to have allowed this to happen, they're all culpable. And that is what we'll say, because we cannot have such a big hospital, which is the centre of excellence, falling into disarray under our leadership here. And we do not intend to let it do so. We will take it further. And if necessary, we will meet the Secretary of State, because we've got you now, but it's what's gone before. Michelle has referred to these stillborn babies. Why on earth weren't they recorded? Why wasn't it made known? Why are these people who've had these stillborn babies made to feel it's their fault? It's absolutely wicked. And it's got to be sorted, but we're not blaming you. It's unfortunate that nobody from the former leadership are here, and we're not blaming you. We hope you're going to pick it up, run with it, and make some sense out of it. But we cannot, for the sake of people of Nottinghamshire, allow this to go by without us picking it up as a committee and saying, why did this happen? And, you know, if I'd have lost a baby like that, I would want certainly to know what happened, how it happened, not just brush it under the carpet and leave people who are sitting there with a baby that has died with no food. It's absolutely inexcusable, but it isn't your fault. But it is the previous leadership, and the whole lot of them are responsible, and they need to go. And they need to make way for people like you and Sharon, who can come in and run it with some credibility. And unless they go, we will never put it right. It's as simple as that. Vice Chairman, you wanted to come in. I'm very mindful of the time, incidentally, but this is a massive subject, extremely important, and we need to get to the nub. Vice Chairman.
Thank you, Chair. I think I opened my comments by saying that this Health Scrutiny Committee takes scrutiny of Nottingham's health services very seriously, and I think that's resonated very strongly. And this morning, again, I've been moved to tears by what you've shared, Councillor Welsh, and I just wanted to make a couple of comments on the back of that. Like you, the information I've shared is just scratching the surface. I've just brought some initial headlines, if you like, and I've not spent all that long. I've put a lot of effort in, but as an outsider, the information that I, like Councillor Welsh, are receiving goes to the heart of NUH. This is a wider issue than just maternity services. I just wanted to make a brief comment as well in respect to the staff and to the midwifery staff in particular and the doctors. I've had staff that I've spoken to, I'm not going to break any confidences, in tears at the loss of each baby that they live with for the rest of their lives. So yes, of course, the parents are not to take away from the horrendous grief for the families, but also for the staff. I go to work and come into this chamber and I shed a tear and I leave and I watch. For these people, they go to work and the consequences are life and death, and it stays with them for life and it scars them. And I want to honour those staff that still get up tomorrow morning, go into work, roll up their sleeves, and they're there delivering my children's, my babies, your babies. And as a committee collectively, we stand together and I want to honour them. I'd also just like to say as well, just back into leadership, again, not to go over this, but other medics, as a result of my research, Michelle, and I'm sure you'd sense the same, suddenly you open up a hornet's nest and you find people coming to you from nowhere, people I've never met from all across the county, wanting to share their stories. And a number of those very, very, very senior medics right across NUH. And my feeling is, and I might be wrong, but I don't think I am, that there is no confidence in senior medics towards the board of NUH. And the CQC appears to have come to the same conclusion. And just reading some of the headlines, it says of the management, the board, you're working in silo, poor working relationships between certain members of the board. Some leaders lack integrity. They focus on the trust's external reputation rather than addressing the challenges. Staff did not always know who their leaders were or what they did. This is what the Care Quality Commission report says. This is what senior medics are saying to me. So we bring these things to you with the most heartfelt degree of sincerity, in the hope that together, and the great joy of this committee as well, and I think we've proven it, is it's not a political committee. We're here as the people's voice for Nottinghamshire, And I hope the people of Nottinghamshire are being served well by this committee. But we must, Chair, we've heard, and we must take action. Thank you.
Councillor Lee.
Well, thank you very much. It's I don't know what it is, to be honest. It's quite strange that today of all days was the day that I decided to substitute. As you know, I had a phone call just before this meeting where I spoke to my wife and asked permission to tell my story. I am going to get upset. I know I am. In 2013, 28th of June, we had our daughter that was born. She's now 8, Hazel. Sadly, we had a medical issue where she nearly died, and the hospital accepted responsibility. We found out due to speaking to another midwife that the same midwife who was responsible for the issue that happened with my daughter made the same mistake with somebody else. And she decided to leave before she was pushed. We spoke to the hospital. We had the main senior person of the hospital turn up. So if you want to speak to the main senior person, your daughter needs to die on our close to death for him to attend. Just to show how serious that incident was, is the senior person at the hospital turned up to my wife's bed 3 hours after my daughter was born to make sure we weren't going to sue them. And then we had to have an appointment with the hospital, I think it's about 6 weeks later, where we were pretty much ambushed with senior people for the hospital, what I now know were solicitors for the hospital, to make sure we weren't going to take legal action against them. We weren't aware of this at the time. We were just happy to have a daughter that was alive and well. We made it clear that we weren't interested in money, or we weren't interested in taking legal action against them, but had assurances that they were going to look into it to make sure that this didn't happen again. Sadly, from the reports, it looks like they didn't keep their promise on that. And it is absolutely heartbreaking for me and my wife to know that things like this happened again. Then a few years later, my little boy was born, David, who was born healthy. Sadly, there was another medical incident where responsibility was accepted, and my wife was rushed into surgery, where she nearly died, where she nearly lost her life. And my little boy and I were left. We're left on our own for 2 hours, not knowing if my wife was going to survive. I wasn't allowed to use the joint toilet, so it meant I had to leave my little boy alone in the room on his own. No food was supplied, and I had to lie on the floor. I am now getting quite cross that it's constant mistakes by the hospital, constant mistakes by the leadership. And we are seeing from the reports that in 2013, 2017, they are not learning from their mistakes. And I will agree with Sue Saddington, with everybody here, that the leadership must go. Thank you very much.
Thank you. Thank you. I don't think you probably need to answer that. Thank you, Jono.
Can I just to say sorry that was an absolutely awful.
I think it's very clear from what we're seeing that we're having personal feelings here. And as has just been alluded to, it's happening over and over again. My own daughter had a problem. I know Councillor Barney's wife had a problem. And I bet we could nearly take everybody in this room who's had a problem over what is supposed to be a natural childbirth. It is very, very concerning. It is even more concerning that this was happening long before you came. And the senior leadership at that time, whoever they are, wherever they are, did nothing, absolutely nothing, to make this situation better. It's inexcusable, as I'm sure you'll agree, and to hear such heartbreaking stories is really quite concerning. And I'm sure Rosa from the CQC is noting all this because it is just true to the report. So let's move on because we have got some other issues. Councillor Cubley, please.
Thank you, Chair. I know you've already touched on this subject, so if I duplicate anything, you'll have to excuse me. It's regarding the 91 million in compensation. I think we need to know the exact figure, please. And B, we need to know the timescale you're going back on that exact figure. And then also, can we know the number of cases that compensation relates to? And also, have you got anything in somebody's in tray, like somebody's filled out a form, but it's not being acted on at the moment, so we know what might be coming down the road in the future in terms of compensation claims. So thank you, Chair.
Thank you.
I'm absolutely happy for us to share whatever is publicly able to be shared. So, and I don't know what that is. I need to take the question back. So I know. So, for example, I know when inquests are coming up and things, but what we have to be careful about is to protect people's confidentiality. So whatever we can share, then we will share.
Yeah,
with
but
the
of course
council.
we're not interested in the names.
No,
we're not
but
interested.
Sometimes if there's only one person, it can be.
Yes, I realise that. I realise that.
Whatever we can share, Councillor, I'm happy to share with you. And
but
I will
of
pick
course,
that up.
these councillors in this room are on an oath of confidentiality, and if it means us getting to the bottom of this, and believe me, I've got enough members behind me, we will do so, and we need that information
it's
to do it.
It's about the family's confidence.
Yes, of
so
course, I appreciate that. To share. But nothing will improve if we don't get the information and
whatever can be shared, I will share.
Councillor Cubley again.
Sorry, I'm not asking for any personal information about anybody. All I want is a figure.
Yeah.
So, if it's 80 million you've spent on conversation over 10 years and the number of cases, I don't want personal information.
It was the bit going forward, Councillor, that I was concerned about. I don't know what I can give, but I can certainly tell you what we've spent on litigation and how many cases that is. Absolutely.
Well, somehow the press got it.
Yes, well, it's out there. I mean, I'm not hiding it because it's publicly available. Most of that. It's only the bits that.
No. Well, what I'm talking about, cases coming forward. Again, I'm not asking for names, but you must know if you've got an in-tray of 100 people or 1,000 people that's not been acted on. You can just say yes. We've got a.
Well, we'll have a legal team that will know that information.
Yeah,
I'm sure.
Yeah. If you can just, like you say, we don't want personal information.
I'll take that as an action. Whatever we can share, we will.
I hate to see that you're having to take so many actions for which you're not responsible, but we have to bottom this. We really do. Councillor David Martin, and then Councillor Gowan.
Yeah, thank you, Chair. I mean, I think we can all agree that it's clearly an emotive subject, as it would be, as you would expect it to be. But it's also very evident that there's been a lack of communication in the past between the board and the rest of the staff, and it could be a much broader issue for the NUH as a whole, which is something we probably ought to go into, which is why councillors are calling for such serious levels of scrutiny. Obviously, part of that problem stemmed from the lack of staff that you had. Now, we know that employing people in the paediatrics is difficult and in midwifery. And I would suggest that is, and I'll go to your bellwether indicators, because you've got your mandatory training rates and your appraisal rates. That's set nationally by the NHS, isn't it? So that's probably part of the issue, because it's not attractive to younger people to come into that realm because the pay is not as good as it would be in other areas. Now, that's had a double whammy effect on the existing staff, because they've been under pressure because they're understaffed. So that's, I mean, you came to the conclusion yourself you needed, was it 18 more midwives? Yeah. So that clearly shows the hole in your staffing level and your staffing requirements. That's put pressure on your current staff, and that's why you've got an exodus of older members of staff leaving, because they just can't cope with it. They've got to that stage in their life where some of them are becoming grandparents themselves, and they're just not up to it. They don't want to do it. I've spoke to a couple of them who have come back on a part-time basis, left and come back because of the void. And as far as the CQC report is, it happened at Sherwood Forest Trust Hospitals in 2016, and we clearly know from that time that it wasn't the staff that were at fault, it was the management. And it clearly was the management, and that management at Sherwood Forest Trust Hospitals has been changed, and since then they've become an exemplar hospital. So we know for a fact that the breath of fresh air that you're bringing in, yourself and other colleagues, is what's required, because there's definitely been a lack of communication and a lack of understanding about how it happens. as far as feedback goes to the NHS, appraisal rates, that's a key bellwether indicator to draw youngsters into, you know, becoming midwives and into that profession. We know that because they can get an easier job, better paid elsewhere. I'll just give you a typical example. My daughter is on a course at university that would cover that area, and as a placement, they've sent her to a bookshop. It's bizarre. So the communication between the NHS and how you recruit people needs to be much greater. And we can all share experiences of malpractice from hospitals and this, that and the other. But I'll just give you an idea. I replaced all of the wards at City Hospital. I replaced all the windows. And whilst I was doing it, I learned that I go to work and my biggest concern is that I've broken a glass unit or dropped a piece of material onto the floor and it's dinted it and my public liability is going to get a hammering. People in hospital, their issue is people die. That's what happens. That's their daily reality. So it's a different world, and we can all go on about it, but that's the reality, and that's where we have to ensure that the people who are in charge of running that ship, because it is a big ship, are doing the right thing for our residents and for our own families. And that's what you would expect us to do, because that's what we were elected for. So I agree with all the sentiments from Councillor Barney, Councillor Saddington and Councillor Walsh, and I feel sorry for anybody who's had the experiences like Councillor Lee, because I myself, my wife was in labour for nearly 48 hours. I had to go to a 24-hour McDonald's because there was no food provision for me, and that's 10 years ago, more than 10 years ago. So, you know, so it's been going on for a long while. So, you know, we are just here to make sure that it's run in the right manner, and it's not a reflection on you personally. You know, right. Thank you, Chair.
Thank you. And moving to the last speaker, which I'm sure Michelle will be very pleased about, and it's Councillor Gowland, please.
Thank you. And I feel almost like I shouldn't speak because so much has been said that's so powerful, but I do want to bring up some specific details at this point. So although I do recognise that you are new and taking over, I would really be grateful if we could have graphs that go back before January 2020, because we know these last 2 years are not normal. And I think it's unfortunate that this graph only goes back a few months, because this doesn't really show us the trends, you know. I mean, you know what I'm saying. But also, I think we need this data compared to our peers. You know, this means nothing to us in isolation. We're not experts. We need to see what's happening, you know, at Sheffield and at Bristol. And I want better than that. I don't want Nottingham to be the average for the UK. Nottingham University Hospitals NHS Trust should be aiming to be the best in Europe. You know, we should be comparing to what's the mortality rate in the Netherlands, what's the mortality rate in Norway, where we know we can be aiming for. I mean, I appreciate it's a different system, but that's what our goal should be, not to just be not as bad as the worst. As has been said, you know, getting the data on recruitment is not good enough. We need to know the number who've left each month. And finally, on the bullying and culture, the words you've used today are really encouraging to me. We know that leadership starts from the top, and we know that bullying comes in cultures where people feel defensive and scared. And, you know, confident, thoughtful management is the way to stop bullying, and attention to detail. And I'd really like to know how often those chief executive teams have been on the wards like you have. You know, how many times do they walk around the wards per week, per month? Because I'd have thought they should be there. One of them should be there every day, particularly in this unit. And I mean, I don't expect you to answer that question. I don't expect you to know, but that's what I think we should know in future when they're down on the wards. Thank you. One more thing. I'd like to reiterate Michelle's question. Can we call for a public inquiry into this situation, please?
We'll certainly have a look at that, Councillor Gowland. I personally see no reason why not, but I must take the advice of officers. I am quite happy to take this as far as it needs to go. It has to stop, it has to improve, and we have to be accountable to those people out there who we represent. And we can't have any more deaths than is absolutely unavoidable, and we will work to that aim. So with that, Michelle, I'm going to thank you because I know Rose is sitting there. Thank you very much, Michelle. I really feel you've been at the sharp end, and it's most unfortunate because you've only just come in, and I'm sure you put your hands up and think, what on earth, how on earth am I going to start here? And I don't blame you if that's what you think. But it is the former senior leadership to yourself that I'm referring to. And they have made errors, and we have to raise this to the Secretary of State. There's no doubt about it. There's been so many incidents. Clearly, we haven't still heard how many, but there have been many. And the fact that the CQC have given you such an appalling report, I think for the sake of the people out there who probably having babies want to know that something is being done and their babies will be safe. So thank you very much. I'm sure you're going to wait probably while Rosa gives. Rosa, I'm going to be very rude. I have a message here from my officer, so I'm going to blame him, who says, can we have a brief report? Thank you, because we do have 2 more issues after you. But I'm very grateful for you coming, and even more so that you're going to refer to this report.
Chair, thank you for that. My paper's in 3 sections.
Microphone, Rosa.
My paper's in 3 sections, Chair. It talks about the system maternity transformation programme moving forward, the local maternity and neonatal system. It talks about what the CCG and partners have done for assurance since the CQC report and over the last 6 months. And then it talks about the review. What I'm intending to do, given the pressures of time, is very briefly talk about the assurance, especially referencing the point Councillor Barney made earlier on. And then I will move on to take the majority of my time outlining to committee members the review that is in the process of being commissioned, the expectations of that, and take further questions on it. So, as Councillor Barney quite rightly said in our report, we've done a huge amount of work over the last 6 months, working with the Trust to develop a number of areas of increased scrutiny, governance oversight, attendance at the CCG on internal meetings after recognising concerns such as those Councillor Welsh shared around failure to recognise and report incidents appropriately. But as he rightly says, until fairly recently, we haven't seen the progress with a comprehensive high-quality maternity improvement plan that triangulates to a clear set of metrics and, more importantly, is demonstrated in a number of key improved outcomes for women and their babies and the citizens of Nottinghamshire. We've been absolutely really clear, both ourselves as commissioners and the regulators from NHS England and Improvement, who share that assurance oversight with us, that that's not a position that is acceptable. What we are doing is working incredibly hard in a really proactive way with Michelle and her team to move that on at pace, working to address some of the issues around capacity through working with system partners to release additional support from Sherwood Forest, from Notts Healthcare Trust, from other areas of our system to provide support where we can. That said, those meetings are well established. They do have representatives from within the local authority. The Public Health Director send a representative to our assurance meetings, as do Health Watch colleagues, to ensure that those are robust and doing due diligence in holding the Trust to account for the improvements that we and the Trust want so desperately to see. What I'm going to focus on talking about today, however, is the independently led review of the maternity services in NUH. There has been not much noise around this in the press, and I believe in a number of constituency areas. The review has not yet started. It is in the process of being commissioned and been established. We identified, following a review of a number of serious incidents through our LM&S Serious Incident Review Group, that much like the stories Councillor Lee and Councillor Welsh have told us, there were a number of things happening and a persistent failure to learn from some of those incidents that were being raised. We've taken time to commission the review because we wanted to be engaged with families, with the families you've talked about seeing on the Channel 5 news. I personally have met with most, if not all, of the families featured on that article, a number of our Maternity Voices partnership leads and other people to shape what the terms of reference will look like to ensure that it does everything that those families need. So what it will do is look exactly as Councillor Welsh has said at why the learning has failed to be taken, not only from previous work internally in our own system, but from a number of maternity reviews across the country. So why wasn't that learning embedded? What is it around serious incident notification that's an issue? But more importantly, what was the barrier to the change occurring that was needed? It will review back to 2016 a huge range of data sources to look at themes and trends. They will include board papers, they'll include staff surveys, they will include a huge number of things. That will then outline the key areas for a detailed review to look at. So if it, as I suspect from some of the conversations we've heard today, identifies that care after the loss of a baby is a significant area of concern, it will look at that and identify learning and recommendations for the trust to embed. More importantly, it will have as a significant part of the review, a families group that's been established to be representative of the citizens of Nottingham and Nottinghamshire, to both ensure that what the review is looking at matches people's experience of the service, but also so that the families are an integral part of taking the lessons learned out to the wider system. I'm really keen that that review is independent. The terms of reference have been drafted in conjunction with the families by myself and colleagues from NHS England. The review is being commissioned by Dr. Nigel Stewart and Dr. Amanda Sullivan, in that they are the leads for our organisation, and therefore the review has to be paid for, and in our governance structures they are involved in that decision making. However, the detail of the terms of reference, the last say on what was in there, didn't go to them, it didn't go to me, it came to the families. Every single item of feedback that families gave us that they felt should be included, whether that was a lack of support in the coronial process, whether that was a failure to recognise deterioration or incidents historically, they've all been included in the terms of reference. An independent investigation team headed up by Cathy Pert, who has never worked in Nottingham and Nottinghamshire or even in the East Midlands, but has a strong reputation as a clinical leader in the north of the country and currently in Staffordshire, will be the programme director for that independent review, supported by an independent midwife and an independent obstetrician, both who have been involved in some of the high-profile reviews around maternity we've seen in recent years. The reason I didn't share the review terms of reference with committee is that they are currently back with families saying, you told us, we've done this, are they fine? And we expect them to be published this week. The Trust are, of course, aware, as many of you are, that we are in the process of commissioning this review. We're not yet at the stage where we've formally met with the Trust to outline the expectations on them of undertaking this review, and that meeting is expected to happen in the very near future. As I outlined, that independence element is critical, and alongside that review team, we will also have an independent investigation team which will independently investigate any areas where it's felt there should have been an investigation earlier, but these incidents weren't recognised, such as the stillbirth Councillor Welsh refers to. So where we, through the process of undertaking the review, identify professional referrals of individual clinicians, families who haven't had an investigation completed, or indeed cases where a duty of candour has not been appropriately carried out, they will all be referred into the independent investigation team who will ensure that that happens. I recognise that will come too late for many people, but I just wanted to give assurance to you here today about the robustness of that process that we're outlining, and to assure you that as soon as we're able, and apologies Councillor Welsh if the partnership briefings we've been providing haven't reached you, I will speak to our comms team to make sure they reach all the members of this committee, but we will ensure that the communications is robust around it, those things that you've talked about such as an independent website, an independent families group. The reason they aren't set up is I don't want it to be part of the CCG. I don't want it to be part of NUH. I want it to be something that our families can really truly believe is independent and leading every step of this so that they can get the answers that they need. So on that note, I've nothing more to add and I'll hand over for questions.
Rosa, I must thank you very much, and I must apologise to you for the wait that you've had, but I'm sure you've found sitting here very useful this morning. Could I just ask, how long would this review take, do you feel?
So what we're really keen to do, so my day job is working with Michelle to do the quality improvement to make sure the quality of all our services is right. It's really important that this review doesn't report in 10 years' time, but that it impacts that today. So we're hoping the review will start forming this month, commence towards the end of this month in November, that investigation phase, and run for a year, feeding regularly its learning back into the trust so it can shape and amend its actions, but formally report in a year's time. However, I fully recognise that that independent investigation process may take much longer than that to complete, and that's one of the reasons, whilst it's sat under that umbrella of independence of the review, it is slightly separate because that might be an element that will take longer to complete for some families or for some cases.
Well, thank you very much. Does anybody have any questions, or are we going to wait until Rosa can come back and give us a little bit more information? Is everybody happy with that? Councillor Wilmot.
Just one little question. I'm just a little bit concerned of the outcomes of the review, and how many organisations are you actually consulting with? How are you getting anybody from all of the districts, the Bassett Law, Broxtowe, Ashfield, Gedling, because they all have different issues because of the way people live, unfortunately. So I just want to make sure that the review continues and you get everybody's viewpoint from all the areas. Thank you.
So, Councillor Wilmot, absolutely. One of the explicit sentences in the terms of reference is around the panel that shaped the review, the families panel, being representative of our system so that it does exactly that. We don't have a small group of people from one particular area. What I have done is, Cathy, who's leading the review, we're drawing up a list of key stakeholders, which includes many members of this organisation, and I'd be happy, Councillor Saddington, to ensure that you and Councillor Barney as Vice Chair are on those lists of key stakeholders so that we can make sure that we're regularly updating you and giving you assurance on that particular issue.
Thank you, Rosa. Just one more, Councillor Welsh.
Yes, and I do promise it won't be as long as last time, honest. It'll be as quick as possible. A couple of just things about the independent review that I feel that I have to say now before it progresses any further. With regards to the fact that there are two people that are former employees of NUH involved, and they are the commissioners, and we have to accept that they are the commissioners. So I have to look on past evidence as well, where, as I've said again, in 2018, there was a review by Not CCG that nobody ever heard about. Now there's going to be another independent review, which I do feel we will hear about. And this isn't against anybody personally. This is just looking at evidence and looking about what happened in the past. When you commission a review, it's the same in nationally as it is in locally. When you commission it, you become owners of that report. That's how it works. And that's how nationally, when we've seen in the past leaks 10 or 20 years later of parts of a review that were never, ever published, because the owners of that would make that. And I'm not saying they would deliberately make that decision. What I'm saying is that they would own that report. Well, I think that report should actually be owned by someone outside of the NUH or has anything. And I think that is to protect those as well as everybody else as well. So that's my first point. The other point that I'd like to bring on is, again, I know that Councillor Saddington, I think feels the same, but I'm sure she'll give me a look if she doesn't feel the same. It's with regards to this independent review, and I think sometimes people don't take us as seriously as what we should be taking with regards to this self-scrutiny committee, because although a lot of us have been quite critical today, I think you can quite clearly see from the emotion that actually it's something we feel quite passionately about, as you do. You can clearly see that as well. It's something that just little things about keeping us up to date with regards to the independent review would alleviate some of those fears and apprehensions that I have about this independent review, because I do know that people are working really, really hard on it. And I am worried. I am concerned about how independent on it, but that's because I can't let go of what's happened in the past. And whenever there are former NUH involved in it, I've got that worry and I've got that fear. So I think any of the information that you can supply to us about what's going on with regards to that independent review, or having even a separate meeting so we don't ask so many questions in this meeting, I think would be really worthwhile, even if you send it to Councillor Saddington or to Martin Gately and he gives us those information, so you're not sending it to everybody. But I really feel that there has to be some better communication with us with regards to what happening.
Is it possible, Rosa, that you could come back and just give us updates until this thing is finalised?
So I'm going to say no, because I'm the wrong person. The reason we have an independent programme director is absolutely to avoid what you've talked about, Councillor Welsh. If I own this review and it's for me and it criticises me, and we've been absolutely explicit that NUH is not an island, and that review will also look at, beyond NUH, what support did they receive, what did commissioners do. What I will do, and I'm going to meet Kathy Pert this afternoon. She's spending 2 days a week here in Nottingham, based at Trentbridge House, while she's carrying out that review. And I will ask her to meet with Councillor Saddington and Councillor Barney, and for her to come back here and update the committee as the independent review programme director. I'm happy to come back and talk to you about the assurance and about the improvement plan and how we're doing that. But one of the things I believe will make this different is this transparency right from the start, about being open and honest with partners, about the independence of the review, and allowing that independent review director to have access to partners. We've also heard some of the concerns you've raised from the families I've spoken to, and we've worked with them to get assurance around both the involvement of Dr. Sturrock and Dr. Sullivan in the review, so that it's really explicit. They didn't sign off the terms of reference, they just accepted them. So the terms of reference, I led on those. They were worked on by me with the families, and they were presented to them as a completed item for them to take note of rather than to comment on, because those things are really important and they really matter. So I hope that gives you some assurance, and I'll happily ask Kathy Pert to contact Martin to make the appropriate arrangements to feed back to you, and even to meet with you privately, Councillor Saddington.
Thank you very much. Just quickly, Vice Chairman.
Super quickly, yeah, absolutely picking up on Michelle's comments and agree. But I did take some comfort from the fact that, as I think I said, the words that you presented here are pretty damning. It's not a whitewash, what you presented to us here today. And I take comfort from that. I also take comfort from the competence that you present here today. But you can, as you can see, Councillor Welsh and I and the whole committee are watching. So long may that continue, that independence. Thank you.
Thank you very much to you both. It seems to have been a long meeting and we haven't finished yet, but thank you very much, and I'm sure we'll be in touch, and I'm sure you'll be coming back to see us, Michelle, and I'll leave Martin to liaise with you on that. Thank you very much. Thank you. Oh, I can't hear.
I was going to say, I'm back in January.
Yeah, January. Possibly January, Martin thinks. Thank you, Michelle. Are members all right? Are we still all together? We're going to move on now to the, where are we? The Basset Law Travel Plan. I don't actually think that will take very long. And then, of course, we have got the briefing on mental health. I think this needs to be briefed today, and we will pick it up and we will sort out our questions. And Glyn, I know you're wanting to talk to the travel plan, aren't you? Right. Good afternoon, both. Come in. Welcome. I'm sorry, we're running very late.
Central button on the microphone. Yep. It'll illuminate at the top when it's on. If you could press.
So can I just check? Are we talking to the travel package or are we talking to the mental health?
So this is, the request was that the mental health crisis would be first, Chair. So that was from the presenters.
Right,
so
okay.
That is the first item. Idris is waiting outside to do the travel plan.
Right, okay.
So Chris and Dave.
So you're talking to the mental health crisis. And we have, let me see, we have Victoria with us, do we? No?
This is Kezia Foster, Chair, and Chris Ashwell.
Oh, I haven't got these names on here, but anyway, sorry. That's fine. That's right. Well, you're very welcome anyway. So would you like to give us a briefing on what you want to tell us, please?
If you wait one moment, Chair, I'll get the presentation on screen because I think Kezia's going to do a presentation.
I do apologise for the wait. We're just waiting for the slides on the screen, members. Little IT hiccup.
Okay,
no, here we go. Good, thank you.
Okay, good afternoon, everyone. I'm Chris Ashwell. I'm a nurse and I'm also the Deputy Director of Mental Health Services for Notts Healthcare Trust. And this is my colleague, Kezia Foster. She is the Notts Healthcare Trust Transformation Lead. So you've asked us to talk about crisis, and we've got the slides on here. We also sent you a paper, which was an update on some of our transformation. So I just want to give a summary on that because, you know, we can't separate crisis from the rest of the mental health pathway. They're also, you know, inextricably linked. So just a quick briefing on the previous paper you had around COVID. Start with COVID. We've had minimal derogations really through COVID. So we've worked really hard to maintain our mental health services. We have had some staffing challenges through COVID, and currently we have a 8% absence rate, but even so, we're still trying to maintain all those services. We've had challenges around beds where we've had to cohort patients, so had to lose some beds. And we've had issues around staffing, and that's particularly the case when we have an outbreak, which we do on one of our wards currently. What tends to happen is we rely on temporary bank and agency staff often, and they cancel at the last minute when they know that there's an outbreak. So that's COVID. In terms of some of the things that have sort of not gone so well, I guess, in transformation and over the last couple of years, we still are not really performing as well as we would want to around CAMS and CAMS eating disorder. We've recently secured more funding for that, and recruitment's underway, so we're quite confident that we will start to perform better when that gets in place. And our step 4 psychology as well, we've just got long waits in that, which is not acceptable. And we're reviewing that along with our CCG colleagues and putting some temporary funding into that to try and address the problem. You'll see from the paper some of the more positive highlights. So our local mental health team waits have reduced significantly, IAPS and early intervention psychiatry. That's also really got good performance against access and waits. We've got a personality disorder hub. which is starting to show some real sort of benefits to the whole pathway. And we've now got 14 senior nurses working in primary care in the PCNs, working closely with primary care and linked to our services. And they're all integral to the crisis pathway. So moving on to the crisis update, if we just move through the slides, you'll see there we are working towards core fidelity, which is a national standard to work 24/7 in crisis services. We've seen some real benefits from that already, which Casey will go into more detail when she goes into some of the graphs. But we've added at least 30 whole-time equivalents, some of those senior people, into our crisis services. Our children and young people's crisis services, we've now expanded, so they have 24/7 coverage. It wasn't previously. So that's a real sort of added system offering for young people. We've got a crisis self-referral line, which people can call 24/7 to talk about their crisis or mental health needs. That's done in collaboration with Turning Point. We've developed crisis sanctuaries across the county, along with the VCS, and we've expanded our street triage team, which is where we have nurses, psychiatric nurses working with the police. And we've also developed our older adult offering around intensive home treatment. So that's support for older people at home with functional mental health and dementia. So Casey is going to now talk a bit more in detail along some of those issues.
So you can see the increase in new referrals into our crisis services. And as Chris said, a lot of this aligns with the new investment. So a couple of years ago, just before the pandemic hit, was when the investment was first agreed. I think we came here and talked about our plans, and we said that we'd come back and do an update. The result of that has been a significant increase in capacity to serve those new referrals, but also the access line, which was part of the response to the pandemic. So that was an action that was done last April. That provides 24/7 self-referral to crisis, and that's a real point. One of the key points that you raised last time was that you had to go through a GP to get access to mental health crisis services, and that's no longer the case. If I can have the next slide, please. And again, new referrals have gone up alongside that. So the conversion rate from people referring in, but also being assessed by the crisis team, has seen a significant upturn. This is in spite of the pandemic, and whilst there are still lots of development work to do, and that is ongoing, we are seeing a positive trend in terms of our ability to respond, and that's part of the increase in resources. If I can have the next slide, please. Just to add to this, so as part of the 24/7 crisis line, like a lot of other areas, we've worked with our voluntary community sector to front that line. So we've got call handlers that we work with through Turning Point. And a lot of people that call require emotional support as well as sometimes crisis support. So what we're trying to do is provide a multifunctional offer so that we're not signposting people, well, you're not in crisis, so you've got to ring somewhere else. We're trying to kind of provide a one-stop shop. This will develop further over the coming months, and there's growth planned within there. But we've already seen quite a significant shift of the way that people use that line and that people are calling for emotional support. And as you can see, quite a few people, around 70% of calls are resolved with no further action by the crisis team. So that's not to say that people aren't referred into our standard kind of local community mental health services or into psychological services, but crisis response is not always required. And that was real strong feedback when we talked to service users, that it's not always the immediate crisis response, but they do want some emotional support with the right clinical support behind it. Currently, what we're seeing is the ages of 30 to 39 are the highest users of that service, but we know that younger people tend to require the crisis response. We're also doing a lot of work to look at how older people are accessing these services. We know that they don't tend to call the crisis line. I'll talk about crisis sanctuaries in a minute, but they also don't tend to access crisis sanctuaries. So we're working with Age UK to see whether there's an alternative offer that we might look at to make sure that we've got equity for older people. Can I have the next slide, please? So crisis sanctuaries, these are available across Nottinghamshire and Nottingham City. They're currently a collaboration between Turning Point, Framework, Mind and Harmless. And that's because they had the geographical spread, so they partnered up. There's plans in place to grow. There's a crisis sanctuary collaboration where we're looking at where we deliver these services, how we might develop that in the future. And if you visit Crisis Sanctuaries Nottinghamshire, you'll see a full timetable of where these take place currently, and they offer a combination of face-to-face and online support, and you can call for support as well. So that's on top of the crisis access line. Next slide, please. Just a little bit on impactability. This is it's a really difficult one to track, particularly because we've not had a normal 2 years. But we have seen a definite decrease in the number of people requiring admission. And one of the key points of core fidelity is that all admissions are gate kept by the crisis team, because only the crisis team really know what resources they've got to manage somebody in the community and what they can really offer in terms of intensive home treatment. But you can see that there's been a marked reduction. That is impacted in terms of our patient flow. So what you'll see reported is we've still got high inpatient demand, and that's because through the pandemic we've seen a slowing down of discharges, and that's the availability of specialised supported living, community placements that offer an alternative to inpatient admission. And we are also seeing acuity increase, which is also impacting on some of our bed flow. But overall, in terms of impact of putting the resources at the front door, we do seem to have seen a positive impact for offering alternatives to crisis care, to inpatient care, sorry. Next slide, please. So just in terms of the ongoing issues and risks, and I'm sure Chris will pick up on some of this, recruitment to roles is our biggest risk, really. You'll see in the paper there's significant growth across all of the mental health services, £40 million worth of investment going into mental health services across the ICS area, which means that we are shifting staff from one place to another, really. So there's an awful lot of work looking at different types of roles, different kind of clinical roles, and also different training that we can provide. We're working really closely with our voluntary community sector colleagues to build their capacity and to work more aligned with us. I've already mentioned the delays in discharge due to the wider system pressures. We are not an island. We need people to work with us, and people need a lot of services to keep them well. So we rely heavily on that system. And we are seeing some increase in demand during COVID and post-COVID, and that's been around acuity more than volumes in some services. But Chris mentioned earlier around eating disorders. That's a national picture and also a local picture that we are seeing unprecedented demand for both adult and children's eating disorder services. And that's either a surge because there's been a pent-up demand, or we're waiting to see how that works. But there's certainly some increases that we are trying to address right now. And then, as I've mentioned, increased acuity of patients, and that doesn't seem to be slowing down when we talk to our clinicians. That does seem to be something that we will have to work around and look at how we might meet that going forward. I don't know if you've got anything else to add, Chris.
Well, just on the recruitment, really, it is our biggest challenge as an organisation. It's probably our biggest risk, actually, as an organisation. There aren't enough doctors, nurses, psychologists trained in the country to meet the growth that's expected in mental health services. We lose people because we fish from the same pool often. So I mentioned the primary care workers, which is a great addition actually to our services, but we've lost people from the wards and from our crisis services who want to go and work there because it's new and it's innovative and it's promotion often. So it's a real challenge for us. We do try and compete with the market. We've got several private providers and inpatient services in Nottinghamshire. So we've got, we do all the usual things, you know, we've got a multimedia campaign, we advertise on petrol pumps, we offer incentives for recruitment and retention. So we're trying everything that we can to get people in to provide these services, really. It's great that all this additional money has come into mental health, but it's all come at once with the expectation that we move very quickly to, you know, transform our services, which of course we want to do. Thank you.
Thank you. Thank you very much for that. I think we're just feeling very much, well, I am, that we're at the beginning of this and we have to tread our way through it. Councillor Lee.
What a day for me to sub in. We've had the first thing and then we've got this. I know quite a lot about mental health. I've never hidden the fact that I suffer with post-traumatic stress disorder from serving in Afghanistan. It's quite strange. I've always been open with my mental health issues. And I was speaking last year to mums in the playground, and I won't mention any names, but nearly every single one of them was on some form of antidepressants. We've just seen in the news that one of the most senior soldiers has committed suicide. We're seeing a rolling effect of mental health issues. Yes, there's lots of money in there. Is it enough? And the second question is, we now know we're getting to the 10, 15-year point from Afghanistan and Iraq, and we know that usually PTSD takes between 10 and 15 years for it to become an issue. We've got tens of thousands of veterans' families that will be getting to that point. And my concern is, with COVID not being a major factor, but with PTSD adding on to that, we are hitting a major crisis that I don't think is really people are aware of. We know that the suicide rate in veterans is getting higher and higher each day. I don't know much about the civilian aspect of it, but just that alone concerns me.
Who's going to answer that?
Yeah, I absolutely appreciate that. I mean, we have signed up to the Veteran Charter to prioritise access for veterans, but you're right. I think, you know, there's potentially more and more demand on these services, and we're trying to expand our services to meet that demand for veterans and civilians, actually. I think one of the things we really need to try and do is expand the psychological offering, and that's what we're doing. So not to rely just on psychologists, but to enable nurses and train other people up to provide some of those services, you know, in that step model of care. But yeah, absolutely take on board what you're saying, and you know, Notts Healthcare is committed to working with veterans.
Yes.
Are you not concerned that having the influx of veterans coming through will not exacerbate what is already in place? And do you receive any funding from the Ministry of Defence to be able to offset the veterans coming through?
Yeah, I mean, we're always concerned if demand swamps the ability to provide it. I mean, we're part of a veterans network, so we don't get specific funding from Ministry of Defence. Just as our organisation, as you probably know, it's a network providing mental health care for veterans, and you know, the demand is there. So yes, I'm always concerned if demand outstrips supply. I don't think we're seeing anything currently to signify that there's a real sort of high risk of that, but that's not to say it's not there.
Councillor McGrath.
Thank you, Chair. Chris and the lady, sorry, I forgot your name because you, right. The challenging job that you both do is unbelievable, and I'd like to thank you for that as well. But you mentioned support, didn't you? Councillor Lee's just mentioned that we don't get nothing from the Ministry of Defence, which is another mainstay as they're coming through, which is going to cause you problems. So have you an idea in your head how many people you need in them areas, right? It's like we're pillar fighting, aren't we? We'll deal with that, because recently, well, in where I'm from as well, I've had a number of children or 14-year-olds who have got problems, right? There was an attempted whatever yesterday in my area, but both have had problems for a number of years, and they have found that the parents don't want to, I don't like using the word, section them, right? Because obviously they have to go through the process. Some of the more academic people believe that they're better off in their own environment. But through the last couple of years, them in particular, the people I know, right, and have close relationships with, have got worse, right? So have we a plan going forward where we can reach out to them? Because I find a lot of people I've talked to who have these issues, right, there seems to be no backup to help them, especially if they're single mothers, right, or from a broken home or anything. You know what I'm saying? It's as if they're on their own and they've got to deal with it, and they find it hard to find someone to talk to be honest. I mean, all right, unfortunately, I know some of them, right, but unfortunately I can't advise them, can I? And they have said these things to me, right, that they find it hard or difficult to find where to go, Chris. So, thank you.
Casey might be able to give you some more detail, but of course, care for young people and adolescents isn't always solely mental health. The local authority provide a lot of CAMS services, and it's important that we work together in providing that, because you're right about sectioning people, but equally, you know, we don't want to diagnose people too early and give them a psychiatric diagnosis at a young age. But if they do need mental health care, it is important that we provide that. And actually, we have done a lot of work in terms of demand and future demand, and that led us to actually securing additional funding for this year to recruit much more people. And actually, we're pushing again for next year to recruit even more. We have our mental health teams who go into schools across the county now. That started rolling out pre-COVID. So there is a lot going on there, and I think we do understand that demand, but it's a societal problem, isn't it? And we need to get the right balance in terms of how we address that. I think we don't want to consign all of these young people into mental health services, because often when you do that, you know, quite honestly, they sort of tend to be stuck in it for life. So we want to try and help them in the most proportionate way, really.
If you could just
Yes.
answer that.
Yeah.
Thank you for that, Chris. Now, I'll ask the families, obviously, because, and then I'll forward. Another question I was going to ask you, which, depending again on what area of the county you live in, right, you find as well that the police have a lot to deal with it, with people with mental issues as well. Do we have a liaison with them? Because they have a bad enough job as it is, and most of us realise that a persistent offender, right, there's normally substance misuse. There's a number of reasons why they want to be in there, don't they? Because they feel safer, and then, God forbid, they end up, getting the same substance in there. Is there any way that we have a plan that there's like we used to have, and I don't like saying it, we used to have Mapley, didn't we? Mapley Hospital. There seems to be a lack of them now, where there's that, you know what I mean? There's that that care for them, right? I suppose more, I don't like saying it, Chris, more was sanctioned in our day, because we're all a bit, well, some of us are road, right? But there seemed to be more care, because we are getting personal again. Both my aunties were in mental health care. And obviously one worked at Mapley, one worked down London. But I'm on about years ago. And there seemed to be more care then. Is there a plan around that?
So we've got the street triage team that is a mental health nurse with the police, and that's a team that we've expanded that, so that works in the evening till 1 a.m. But we also expanded that to have a day car as well. So that's kind of the police support, and that means that we can take people to health-based places of safety, which is it's a much better response than taking them to a cell. So that's some of the stuff that we're doing. But as part of that, we've implemented a multi-agency post that works with that team, so that when we're seeing people on a regular basis at night with the police and they're regularly being transported to these places, they can do that work with all the partner agencies to look at a different package of care and be more proactive. So while it's not specific kind of day provision, it's about pulling in all those different agencies to come up with a better way of supporting people, which will be substance misuse services, local authorities looking at housing, and other things that might be kind of why we keep needing to be picked up by the police. So yeah, we are trying to look at it in a more multi-agency approach. And just picking up on your previous point about do we know, the kind of staffing, underpinned with all this investment is quite a prescriptive community mental health framework and an ambitions tool that sets out what they expect to see in terms of staffing growth and what they expect to see in terms of all our access rates. And that's really kind of managed at a national level with quite robust assurance processes around that. So I think a lot of the things that you're kind of asking as Councillor Saddington reference, we're right, we are at the beginning, we're in year one of all of this, but there's quite a lot of investment and planning that's gone behind it that hopefully will meet some of the needs. And I think the psychology aspect and the making sure that there's psychological therapies all the way through, that's one of the main components, is that evidence-based psychological therapies are entwined with all our therapeutic pathways. So I think that there's kind of a lot of context behind what we've just presented that is the answer to your question, that yeah, there's been a significant amount of planning that's gone behind it. But we will keep saying that recruitment to these posts and skilling up and training is the fundamental bit, and that's something that's not done really quickly. So that is one of the issues for us.
Thank you. Vice Chairman.
Yeah, I'm going to put my Councillor Mike Adams hat on, because it's Councillor Mike Adams who's absent today who's asked me to bring this. This references a young lad, I think, in his ward. I've got very few details, but I'll just briefly share what I have here. So it's about a young chap who's been diagnosed with OCD. He has dependency issues and he's constantly hand washing and he's completing many rituals to keep his parents safe. He worries about his mum being sad if he doesn't do the rituals. He's got social damage issues. He doesn't want to go outside. He's not eating, and he doesn't want to eat outside, etc., etc. It says here that they sought support through the school, but were told that unless he had suicidal thoughts, that no help would be in place. Finally, they had a letter of confirmation of a referral with CAMS. It says here back in March, but they're yet to still have any actual meeting or any contact. And then, rather worryingly, it says here that they've sought a solution through Facebook, dealing with somebody in the US. And I heard a news article the other day about pseudo and sham providers setting up. So I was quite troubled by this, but that's what he's resorted to. And Councillor Mike Adams has just asked me to pass that on, that you might comment. Thank you.
Yeah, I mean, it's really sad to hear that story. And we wouldn't advise some of these Facebook groups, for people, although, I appreciate they get desperate. I did say at the beginning, we have long waits in our CAMP services. We're playing catch up with that. We didn't have the funding. We've now got the funding. So we're playing catch up with the waits, and there's more demand coming through, actually, in CAMS. I think you'll see that in society in terms of mental health issues with young people. I can't comment on the specifics of that because I don't really know, but if you want to forward us the details, we'll ask our CAMP services in the appropriate area to pick it up.
Thank you very much. Thank you. Councillor Wilmot.
Thank you very much. Yes, mental health issues are a very serious problem. I think councillors realise when we meet a lot of our residents that some seem to have certain disorders mentally and physically as well, and it's been very much a big problem. I just wondered where your information out there to help people. Where do they look for it, and this, that, and the other? Are they ways of finding out all the possible information that might help a lot of people with eating disorders as well? I was concerned that so much percentage of them didn't get seen early enough, and of course you all know that children, if they're in an eating disorder, or if they have a eating disorder problem, it can alleviate, it can make sure that somebody sees them, because it can deteriorate very quickly. And I have had discussions with families where it's been very serious indeed. And you know, that's another thing. Armed forces and prisons. I wondered if you were involved with any person coming out of that situation, either a prison or the armed services, because I was involved just recently with a person who was let out of prison with bipolar and schizophrenia. And caused a considerable amount of problems with walking around the streets. And I just wondered if you do look at prisons and make sure that anyone with a real problem is coming out is met, so to inform them what help they can get and so forth. And you know, and the other thing is in Appendix B, it states that over 8 out of 10 of our mental health patients are followed up within 72 hours. I just wondered what happened to the other 2 out of 10. What happens to them? Do they get left? Does serious incidents happen because of that problem? And I also, can I welcome the reduction in the out of area placements? I think that's an excellent idea. But again, it's got to be make sure that families, carers and friends get the opportunity to see them, you know, even if they do go out of the area. That's an essential part of the help that that you put forward. And I note that out of area placements by March 2022. I wonder, do you accept that that you have missed the government target? And how confident are you that you will meet this new ambition? A failure to do so can delay recovery extremely badly. Thank you very much.
I think I can remember some of your points. So out of area placements, COVID had a significant impact on the overall government target for April 2021, with most areas not managing to achieve it. And that was partly because of the distance. We had to use dormitories in a different way. Obviously, people couldn't share spaces, so we actually lost beds during that period locally. We are confident that we'll achieve that by the Q4, so by the 2022 target, and that's kind of the national requirement now. In terms of where you can find our information, so we've got there's Notts Healthcare Trust website, but we are on Twitter, we're on Facebook, really promoting things like the crisis line, the crisis sanctuaries, where you can get all the support from through our voluntary community sector providers. And we also share a lot of information through the local councils, through the local primary care network. So we are constantly trying to get that information out there, but very happy to share links. From an eating disorders point of view, the information you're referring to is the children and young people's eating disorders. And Chris mentioned earlier that we have seen longer waits, but we're also seeing an increase in demand, which is exacerbating that situation. We're currently in a situation where we are doubling the team size. That's the kind of investment that is required to meet the standards that we are working to. So that's the team is really small, 10 whole-time equivalents. We're looking to recruit another 10 whole-time equivalents and plus more in the coming years. The problem is they're quite specialist roles. And again, it's the recruitment, so that is underway. So we're hoping to see an improving picture over the next few months for that target. There was another point, but I think I've... Prisons. So we have a community forensic team that will support people that require that level of support, but we also have a group that looks at severe multiple deprivation that has that prison focus as well. So we liaise with our prison health teams to try and offer that continuity of care, and there's a small team that support that. But there are some bids that are currently ongoing at the minute to look at how we might develop that further. Which one?
About the, you said that you're on a lot of online stuff. You've got a lot of online stuff, but you have to remember that 40% of the population are not online or anything like it. How are you going to make sure that they get the information?
Yeah, I mean, we try and use all of the kind of methods in terms of getting out there into GP practices where people go, trying to get, I mean, posters have been difficult and leaflets have been difficult over the past few months because they cleared everything out due to restrictions. Looking at ways in terms of, we've got the primary care network practitioners and we've also got peer support workers to look out and word of mouth really and start to go out to those groups. So I think just utilising different ways. What I will say is that if you've got kind of constituents that don't have access, that, you know, that there is a bank full of resources that you can get access to and hopefully share that out there. But we're happy to provide leaflets if you can use them.
Thank you. Councillor Martin.
Yeah, thank you, Chair. Yeah, I welcome the report, but obviously issues brought about by COVID is going to exacerbate the problem and the veterans as well. And young male suicide victims, you know, it's all in the mix, and this money's not before time, although you're only just at the beginning of it. And one of the other reasons that staff are swamped and there's a lot of pressure is also because getting a face-to-face appointment with your GP practice has become almost very difficult over the COVID period. And key workers from across the county are probably burning out because of that. You know, I mean, at Ashfield, we have a complex case team which works close cohesion with community protection and the police. They're based in the hub at Ashfield District Council, so they're all in the same room. They can talk to each other. So that's quite good. It's quite a good model, actually, because they're all in the same building. But in appendix, item 3.3 of appendix 1 talks about the health inequalities, which, without actually addressing the health inequalities that exist. Do you have any data that shows if there are any related to specific areas, you know, or the hotspots across the county for different purposes? You know, I mean, one of the largest increased groups is young people and women, actually, in the latest period for tracking statistical data. Just wondered if you've got like a map of the county, and that's. Thank you, Chair.
So the health inequalities bit of the transformation is the key bit. What we know, and particularly for mental health, is that deprivation trumps all, really, and that's, we need to make sure that we're clear about that. But also there's lots of different pockets of different ethnicities, different kind of cohorts of people that will need a bit more of a nuanced service. So when we're looking at how the services are adapted, we're working at integrated care partnership level, so Mid-Knots, County South, City and Bassetlaw, to really make sure that we're addressing those local needs. So we do have the population health management team working with us, but we've also, part of the transformation team's got an analyst that's going to specifically focus on the health inequalities, but looking broader than what we typically look at, such as kind of BME and things like that. We want to really make sure that we expand it out. So yes, we are mapping that. Yes, we do have, each of the primary care networks has like it has a health profile, but what that doesn't really tell us is, so what works for those groups. So that's the work that's happening now, to look around at what good practice is, how we make sure that, you know, we work with the people that live there to find out what works for those, you know, what would be accessible to you, what does this mean to you. So we've got a lot of information. It's the analysis and the application of what we do with that now, which is the next bit of it. But yes, in answer to your question, it is mapped across deprivation levels, across different profiles.
Yeah, if I may just come back, Chair, on that. So through your online platforms, are you offering a broader service for consultation, you know, with people who are paranoid about coming out into the world because of COVID and stuff like that? Are you expanding that service with this new tranche of money that you've got? You know, are you broadening the technologies? Because obviously a lot of people, it's a very diverse world, as we know. So some people don't like online stuff and some people embrace it. The older generation aren't able to do it, but the younger generation would embrace it. And I just think, you know, some kind of, I know it sounds crazy, but a lot of firms you go to now, or like British Gas and Severn Trent, they've got online people answering the questions all the time. And I just wondered if you're embracing technology in the right way, even maybe with like an avatar doctor online kind of thing, you know, through the social media and through the promotions that you're doing and the platforms, because you've got to increase your accessibility.
Yeah, I'll let you do.
Yeah, so we are mindful of that, and it was really evident in the early days of the pandemic where our non-emergency services weren't providing the face-to-face appointments, either because, you know, of the risk to the staff, or actually because service users or patients didn't want it. They as you say, they were fearful of coming out. So we purchased actually a platform called One Consult, which is a video consultation platform, and we also have Microsoft Teams that our service users, patients and carers can use actually. So that's taken off more in some services than others. In young people's services, actually, it's used probably the most, and in IAP services, so access to psychological therapists, it's used quite a lot as well. In our sort of broader community teams, not so much so, quite a low uptake, but what we have seen is quite a significant increase in telephone consultations. So what we need to try and do is just get that right balance so we can see people face to face where they do want it, because it is important when people want face to face that we do it. So yeah, we've done quite a bit of work in our bases to make them safe for face to face consultations, and I think we'll start seeing more of an increase in that now as well. In face to face, we don't have a doctor avatar. I'm not quite sure what that looks like because I'm not that tech savvy myself, but we are working on different solutions.
I just think that accessibility is key to a lot of people's issues, and if they could get some kind of support, even if it was only small, would be better than the delay and waiting or presenting at A&E, which is causing other problems.
Sorry, I just wanted to add, actually, I didn't add there, the 24/7 crisis line, people can ring that day and night, 7 days a week, and we've really seen increased usage of that. So people are clearly taking that on board, that they can do that, and then, you know, sometimes that does lead to more coordinated care, I guess.
Councillor Welsh.
Hiya. Mental health, so had a massive impact on my family personally due to a very close member committing suicide a few years ago now. And one of the reasons, or one of the things that was established thing, is the fact that he was male. And well, I don't usually like to go into gender specifics, but there's often a difficulty, I think, with perhaps males talking out or saying necessarily how they feel, even though we're actually a very open family that communicates really pretty well. So he was obviously in a very dark place as such. So I come basically from that point to start off with. So and also in a previous role where I did deal with some cases where actually people actually came to the office door where I worked. I was working for a Member of Parliament at the time, asking for help, that they were at crisis point and didn't actually know where to turn or what to do. And even though I did work for a Member of Parliament, I was phoning various numbers, and I was told that because I worked for a Member of Parliament, I couldn't refer that person on to anyone anywhere. And I asked at that time that could actually be changed, because still at 7:30 at night I was on that. I don't know whether that is, but that's one of my first points. The other thing I'd just like to ask as well, with regards to you talked about the Nottinghamshire crisis sanctuaries. They are in various parts across Nottinghamshire, but they're not in every part of Nottinghamshire, are they? Is there some work going on with regards to enable that? I'm actually an MP in Gedling, and I can't see anything Gedling yet. We do have lots and lots of charities and organisations and groups in Gedling that I perhaps would actually come on board with that. And if you needed any help with regards to linking in, you might not, but I'd be really happy to support you that. The other big thing is there was a digital survey, and excuse me for looking on my phone because I read it, and then with everything with maternity services, I've forgotten it, but there was a digital survey with regards to young children's, young people's mental health, which was a national survey, which was really, really recently, where it said on this survey 40% of 6 to 16-year-olds and half of 17 to 23-year-olds said they felt their mental health had got worse over the pandemic, and it found 1 in 6 children in England had a probable mental disorder in 2021. That's huge, isn't it? Are we seeing that in Nottinghamshire? And if we are, my understanding is we're already at a level where actually we're at capacity breaking point with regards to young people's mental health. It can take up to 12 weeks, sometimes longer, to the point where you actually get to see somebody. And as somebody, like I said, that has lost somebody, those 12 weeks actually can be quite critical. There's a lot of pressure on parents. Parents are feel like in that they're failing their children. This has come out in this survey as well, because they're not able, but they can't deal with these complex mental health disorders because you have to go through years of training and experience to be able to help people with some of these complex mental health disorders. So my worry is obviously about everybody, but I just wanted to emphasise, one, about local crisis points, and where as members we can help as much as possible with regards to helping establish them in other areas, but also how we can support or help with regards to improving the provision for children and young people, because it's a real worry, real worry for me. Sorry if that was a bit garbled, but I think I got there in the end. Thank you.
So on the crisis referral, it's self-referral now. So hopefully you shouldn't get that kind of response. So that's been in place for over a year. And we are getting a lot better feedback. So the accessibility there is improved. Absolutely, the sanctuaries, we need to grow them. So there is a sanctuary collaborative group that we work together with the CCG and the partners. Very happy to share that information. They're always looking for new local venues and things. And Crisis Alternatives is about growing over the next few years. It's testing the model as well. And as I mentioned earlier, why don't older people access these things? Could we do something with another specific group? So, yeah, we'd like some support with that. The children and young people's investment, as Chris mentioned, is coming online now. And just to give you a flavour of that just in the community teams, that's 40 whole-time equivalent growth over the next couple of years, up from around 160, something like that. So you can see the kind of scale of the growth that we need to do. So yes, we are at breaking point now, but there's lots of there are some short-term interventions to get some capacity in now to try and alleviate some of the long waits. But this is about broadening out some of the skills as well. So Chris mentioned the mental health support teams in schools. We've now got those in 115 of the schools around the area, and that will grow. So eventually every school will have a mental health support team, and they seem to be accessing things like Silver Cloud, which is an online app, and that can help people. That they don't always need to be seen by CAMHS, but it's about that early intervention, and it's those coping skills, and they can be done in quite a family orientated way. So it's almost aligning the capacity at that top end, but it's also making sure that we've got that preventative end, because as Chris said, what we don't want is lots of children kind of being labelled and badged as one thing when actually the prevention would have probably moved them in a very different direction. So working collaboratively with the CCG, there's a big kind of transformation programme that's being developed around children and young people's mental health, and that's through the integrated care programme. So yeah, that is happening, but real terms investment and growth is actually happening as well. So we're not just sitting here saying we want to change this pathway, it's actually coming alongside investment as well, which I think is probably one of the first times that we've been able to come and say that quite confidently.
Thank you. I'll take the last question from Councillor Gowland, please.
Thank you. I have to say, I think I was really impressed by the novel approaches you seem to be taking. There seem to be quite a lot of things going on, which is really good to see. and obviously it will hopefully bear fruit in the future. On the data you presented, one thing I wondered is, do you have data on representing? So I mean, we all are aware that mental health is a very complex and chronic condition. Councillor McGrath talked about, you know, the old big mental hospitals and people being kept in them for years, but providing a place of sanctuary. Of course, they had major problems and there was a reason they were closed, but if the alternative is going between the street and prison, it's not so great either, is it? So I just wondered if you do keep data on, or have data, I'm sure you do, and could give us data on how often people end up being representing to your services, because obviously if you can limit that, that makes it easier. And finally, what happens to the sanctuary patients in the day sanctuaries, or people, I should say, coming to your sanctuaries at 11 o'clock at night? Where do they go?
So we do have a pot for taxis and support to kind of support people home. So far, we've not had many problems with doing that. We talked about that a lot, actually, what happens when they get stranded, but that doesn't seem to have kind of borne out. As we grow, I imagine that there might be some issues, and we'll watch that. But we did put a flexible pot with the providers to make sure that we could get someone a taxi home, because if they've been brought or they've kind of turned up on a bus, we don't want to be leaving them at 11 o'clock. In terms of people representing, yeah, we do have kind of longitudinal looks at people, particularly certain diagnosis types as well. We always look at readmission within a certain number of days as well, because then we'll look at the discharge. That's something that we're tracked on. And people, you know, we're secondary care mental health services, so people will be in our services potentially for quite a while. And a big part of the kind of next steps is how we bring other providers to support them, so they're not just held in secondary care and they're not really recovering in terms of that wider system. So that data is available in terms of how many times we present, but more often the case is we don't actually discharge back. We will hold on to somebody that's got a chronic mental illness.
Thank you. Thank you very much.
Just one thing to add on that, of course, we don't provide all of the mental health services in Nottinghamshire. So the IAPT, there are 3 providers, so we don't always know when people have been in other services and then presented at ours. So I guess there's a bit of a gap in that, although a commissioning solution is on the way for a lead provider. So.
Thank you very much to both of you. I think what we see from this is that this is a huge subject. It's certainly a subject I think all of us as members are approached by various people, you know, either concerned that they know somebody with a mental health issue, or just generally, can you look into mental health? This is the kind of question that I've had. We are only at the beginning of it, and I think, as you've alluded to, the fact that children, the children issue has raised considerably, I think is extremely important, and has obviously probably followed on from having COVID, them being restricted from school, being away from their friends. They might have changed from junior to secondary school, primary to secondary school, and they've not been able to meet new friends. I think there's been a whole issue there. And you mentioned CAMHS, you mentioned the waiting list at CAMHS. So I think my Vice Chairman and myself and Martin, because we haven't possibly got time to discuss it today, need to look at how we can break this up, possibly into looking first of all at children, the effects on children. They don't want labelling, but they need help. We might need to talk to CAMHS. We might even need a visit to CAMHS to see what they do. And then we have the sort of middle-aged people who probably used to have their coffee mornings and their lunch parties, and that was all stopped, and that might have affected them. And we need to look at the old people and of course the people who were shut in their houses, probably a single older generation, and they're feeling it too. And now everybody's coming out. They realise that it's quite something to have to come out into the open space. So I think it's a huge issue, and I think this will be running for a long time. And we need to break it down into sections and look at children, see how it's affected children at school, and then go across the whole spectrum of the population. So I do thank you for coming in this morning. I feel we've only just scratched the surface, partly because we were running late as well, but also I think now we need to look at it as to how to break it down and how to go on for the next 12 months. So thank you very much for both of you coming. And I'm sorry we were running incredibly late, but our first agenda item really did take a long time. So thank you. Safe journey home. Thank you. Thank you very much. Martin will bring...
It's Idris.
Oh, we've got Idris. Right. I thought we were having Julie. Right, that's fine. Members, we're just looking at this travel package, and then from there on in, we'll discuss quickly next time. I want the agenda slightly less items because I think we're running too late. Good afternoon, Idris. We'll just let you sit down. I'm very, very sorry. My humble apologies to you that we've kept you waiting for so long. But we've probably, have we saved the best till last? Let's see. Would you like to give us a briefing when you've just connected to your laptop?
Yes, thank you, Chair. Thankfully, we're all used to remote working now, so it's no problem. I realise you've had quite a long meeting, parts of which I've been listening with interest. So you've got the paper in front of you. Obviously, this is a follow-up from the previous visits I've made to your committee, but it goes into more detail now with regard to the transport plan. So conscious of time, but I'll give you a very brief overview of what I think the key points are in the paper and the plan. First of all, I think it's really important to note that this was really built up in consultation with the public, with service users, with carers, with representative organisations of those, and obviously we went back and looked at all of the responses that we'd had during the wider engagement exercise, which took place over several months. So quite comprehensive, I think, in terms of how we've engaged people in the development of that. I think one interesting thing that came out of that, and I've seen this a number of times before, where you engage the public and perhaps there's a preconception that they'll approach an issue in one way and then they look at it in a broader, sort of way, or come at it from a different direction. So I think coming out of that engagement, a number of principles were established by which then the plan itself needed to deliver on. And in particular, three things. One was about equity and fairness. So there was a concern that individuals shouldn't be treated in a more favourable way than others. And obviously, I've talked before to the committee about the fact that the facility currently at Bassetlaw is predominantly used by patients from across the county. So some of the biggest users in terms of volumes are not from Bassetlaw, they're from elsewhere in the county. So the principle of equity and fairness came up quite a bit in that discussion. The second thing was it needs to be simple, so people need to be able to access it in a straightforward way. And thirdly, that it's flexible, because each individual case sort of will be different, and it needs to meet the individuals and their family and their carers' needs. So out of that, we said, well, there isn't a one size fits all. We want to involve the patients themselves in the decisions about who they want to visit them, and it should be their direction in terms of how we can facilitate that. That it should include non-financial as well as sort of financial support, and in particular, people were very keen on ensuring that they had a really broad, comprehensive information pack to support sort of their families. On criteria for who was eligible, there were differences of opinion. So some felt that, for example, if you had your own private car, then you shouldn't get any support. Others felt that, well, if you were on income support or universal credit now, then perhaps that should be the guiding factor. One thing I think that did come through is that people shouldn't actually have a greater advantage in terms of financial support as a result of the change. So what the policy itself does is try and address that excess costs for individuals but it doesn't means test it. It bases the number of visits on what the patient themselves would find, sort of most beneficial, and ensures that there is support at a ward level, so as a support worker to actually come about with the plan, sort of alongside the patient. It also includes, we touched on this previously, about digital support, both in hospital, but also the provision of loan, sort of equipment, but also for some people, a little bit of education in terms of how that might be used. I won't go into the details, but because I'm sure there'll be questions in terms of how the excess costs are actually calculated and things, but it is all set out in there. And the two final things I think I just wanted to mention is, firstly, we're talking about patients and the relatives here, but obviously the Notts Healthcare Trust have also spoken individually to all members of staff affected. And finally, you've just had an agenda item on enhanced crisis services. That affects Bassett Law as well. So when we talked about, well, how do we support an adult in crisis, then that very much is wrapped into that. So I wasn't going to duplicate what you've just heard a few minutes ago. I suppose one thing I should have mentioned right at the beginning, just for clarity, and I thought I'll finish on this point, is that where a patient actually needs to be admitted, they will be provided transport through the ambulance service and potentially where needed, a specialist ambulance service. So that isn't affected. We're talking here about visitors to patients who've been admitted to a facility. And as you know, with the potential move to Mansfield and Sherwood Oaks. So I'll pause there, Chair.
Thank you, Idris. If I could just mention before I ask who'd like to speak on it, this isn't the travel package I expected. I really did expect a much more detailed travel package. I think you need a degree to work out how you claim money. And I think when you review it in 2 years' time, it will probably just fall, and that will be the end of it. There's nothing here that says it's a permanent travel package. You have to go from the point of the hospital to the hospital in Nottingham or Mansfield. You've got to deduct this, deduct that. I just can't see people doing that. I just think it's a way of people thinking, oh, I can't be bothered with it and I won't claim. So I think it's disadvantaged people. And I note on page 49 in the report that you actually say there wasn't a consensus about the criteria. You couldn't agree on what was the best financial travel package. And I don't think you've got the best financial package. And we've been waiting 4 months for it. One thing I would just like to ask, because to me, it's simple, but there again, I'm a simple person. Why haven't you thought of a shuttle bus to take people probably twice a week from Worksop or Retford or both to these various sites? And in order to make it profitable, not profitable, to make it more worthwhile, you've got cancer patients which are in Nottingham that can't probably, their relatives and carers probably can't get to see them either. You could offer that assistance to people with long-term illnesses in the Nottingham and Mansfield hospitals. But quite frankly, this is definitely not what I expected. I expected a much more, we have so much money and it will run like this, and whether or not you've got a private car. I mean, to tell people that they will be given a map and a timetable to get on a bus, and that is your travel package, I find absolutely amazing, because they could have done that without being told. We can all do that, get on a bus and go somewhere. I was expecting some cars which were going to be made available to take people from A to B without any argument of whether they've done 20 miles or 25 miles and deduct from this, deduct from that. And so if that isn't possible, I would have thought a shuttle bus was the answer. And if people knew that you went on, let's say, with a shuttle bus on a Monday and a Thursday, then if they want to visit on a Sunday, they can ask their friend if they'd take them and give them £10 or something for the petrol. I don't know. But at least they would know that they could plan their day, that there was a shuttle bus available and they could go to Millbrook or Sherwood Oaks or wherever. And by the time it's done its trip around, it would be coming back and bringing the people back. And to me, that is the most sensible answer. But this business of deducting money for so many miles, and oh my goodness, I mean, they need to be at a degree school to work it out. It isn't what I expected. And personally, I can't support it. So I've got Councillor David Martin and then Councillor Wilmot.
Yeah, thank you, Chair. I think we're getting into different realms here because it clearly says in the report that it's not the NHS's job to provide travel packages, so they're at a loss as to what to do. And you're quite right, a shuttle bus would be more practical, and you do have a bus that you take children to Doncaster and Sheffield University hospitals. You have that bus already that you already have sat there, and you have drivers who are lodged up in a local hotel overnight, which is a great expense to the local hospital. Having said that, you also keep alluding to the fact that a large percentage of the people who are in Bassetlaw mental hospital services, not mental hospital, but mental care services, a large proportion of them are coming from the city and from across Gedling and Newark and Sherwood and probably even Rushcliffe, I don't know. So if we took that boot on the other foot, if I was travelling to Bassetlaw Hospital from here, that's 43 miles, and you're asking people, a small proportion of patients' relatives, to come from Bassetlaw to Sherwood Oaks, that's 26 miles. So that's not anywhere near as far as travelling from here. If I was a resident of the city hospital and I had a relative in Bassetlaw Mental Hospital for whatever purpose, and you're moving the services to improve them, we're getting a bit convoluted, and I'm just losing the thread with it, because the other side to it is, if one of my relatives was being put in Bassetlaw Hospital because of oncology reasons or cancer, they wouldn't get the package. You know, if it was heart, if it was any other illness, they wouldn't get the package. It's only for mental services. So I find that very difficult to differentiate between one service that the hospital provides and that specific service, because you're sort of like marginalising the spread of what you actually do. And of course, that is also not fair to the people who currently live in the city or Gedling or Rushcliffe or Broxtowe who travel up to Bassetlaw currently, because they've never had that. They've always had to go 43 miles for that service. And you're actually moving that service more to a central location in the middle of the county. So there's no wonder the travel package is as it is, because it's confused.com, isn't it? And I think we've lost direction, and I think we need to rethink about what we're asking the hospital trust to do, and actually why we're doing it and how many people we're going to do it for, because we're creating a prejudice, if you like. And I just think it's all wrong. And I know those in Bassetlaw are going to say, oh, you're taking services away from there. But people are already travelling from Nottingham City 43 miles now. You know, so if I was going from here to Sherwood Oaks, it would be 17 miles. But I wouldn't get a travel package if I lived in the city or Rushcliffe or Broxtowe or Gedling or Arnold or even Ashfield. But I would if I lived in Bassetlaw. So we're creating an imbalance, and I don't think the whole thing, I think the whole thing's wrong. Sorry, that's just my take on it, but thank you, Chair.
Idris, do you want to come back on that, or do you want all the other questions and then you'll do them as a whole, which you do prefer?
Well, conscious that you made some points as well, Chair, and I've got Councillor Martin's points. Perhaps I could do them in batches.
Yes, let's have this batch of two then.
Thank you. If I work backwards, so this was exactly the issue that when we opened this up to discussion with relatives, carers and things that they were raising. So why should there be a service specifically put on for Bassetlaw residents who, if we look at Ward B1, for example, only make up about 11% of the patients that go into Bassetlaw Hospital. So the other 89% are from elsewhere in the county. So most of you as councillors, your constituents will be benefiting from the move because it will be nearer to their residents, because it is more central to the county. And that was one of the things that when we opened up the discussion, the consultation about the transport plan was raised, which was my point at the beginning, that people sometimes surprise you, they come at it from a different perspective, and those are just some of the points that were being raised. The issue that the health service is not a statutory provider of transport to public visiting patients in hospital is a statement of fact, but also it's a practical issue. That if you start to, and you mentioned, Councillor, about cancer patients, for example, and patients, I think there's a question of, well, who would you not include? Mm-hmm. And at some point, you know, sort of the health service is providing care. This is a specialist care facility, and therefore we're looking at providing it in the best facility possible, more central to the county. That we feel is a positive thing. I know that therefore is a detriment in terms of access to the Bassett Law residents, not to everybody else, but to the Bassett Law residents compared to what they have now. But it is an overall benefit to the vast majority of patients. So when we look at, and take the example of a shuttle bus, we did look at it. We're talking about 80 odd patients a year, and therefore their relatives sort of visiting them from all over Bassett Law. So it's a big geography. It's the largest district geographically in the county, and it's very large, you know, so compared to other districts elsewhere in the country in many instances. So where would that bus go from and to? And if you do it from Worksop, actually, you're not necessarily reducing the mileage that they do. And if you provide it for cancer, so relatives of cancer patients, so on, then you're increasing the cost. You alluded to, Councillor Martin, about the paediatric transfer, because that's for paediatric patients that we transfer overnight at, as you, I think we're alluding to, at quite considerable expense, because these facilities, once you provide them, I know council provided transport services elsewhere, so you'll be familiar that it isn't the same as just sort of paying somebody for a few hours. If you're actually supplying a shuttle bus with drivers going through multiple destinations. And the point, and I take your point, Chair, about maybe an A level in maths, it's actually something I think we're quite used to in the public sector, because excess mileage claims is when somebody moves base is very similar to this, so it's actually quite common. But the support worker on the ward, it would be the person that would apply for that. We wouldn't expect patients or their relatives to make the calculation. But it comes back to the public engagement where people said, if you are going to provide financial support to Bassett Law residents because it's the change that's affecting them most, don't do it in a way that actually makes them even better off than they were previously, because they have to go to the hospital already. So why would you pay them not just for that distance, but you know, sort of for the entirety? And those are the issues that we really struggled with, and therefore we're trying to find a balance of saying Bassett Law residents are the change is impacting on them. So we did agree that there should be some financial support in addition to the wider change, but they shouldn't be so advantaged that they would get more than they currently do. And as I describe it, the practicalities is then how you calculate that, I realise, can be a little bit complicated, but the staff themselves would do that on behalf of residents.
Councillor Wilmot.
Yes, Chair, I was the same as you. I thought the report would be coming back telling us what sort of services were be available and what the costs were, etc. I mean, if you talk to the taxi companies and promise them that they'll be the only taxi firm to get this delivery service, then they would subsidise it. And I'm also thinking the bus companies would do exactly the same if you put it on to a situation where you can actually say where the pick-up points were and when they were going to be, etc. And also a shuttle services. Again, that would have been a great idea. But what first of all this report put my back up a little bit was saying, be noted that the CCG does not have any statutory role in providing funding for patient family carer access or for patients outside the National Patient Transport Service eligibility criteria. That opens up a can of worms, because It means that people that delivering the actual service or commuting with the or talking to the residents, they could have an open book, and they would treat patients differently. I'm sure that would happen. I'm quite happy with the situation of the services in Bassetlaw for people with mental health needs will remain in Bassetlaw. I think that's an excellent idea. Also, the patient requiring non-urgent patient services will continue to be offered transport support. But again, you've not told us anything about it. What transport supports will happen? And travel plan principles, maintaining fairness and equity for all patients, carers and families, including across mental health and physical health needs, ensure that support offered, both financial and non-financial, is simple and easy to apply. Criteria for accessing support is flexible and adaptable to meet individual needs of patients, their carers and families. That's an open-ended reply as far as I'm concerned, and it can mean anything. But I'm just a simple councillor. Thank you.
We'll move on to Councillor Gowland, and then perhaps Idris, you'd answer those two.
So first of all, on the fairness side of things, as somebody who did have a family member from Rushcliffe who had to commute to Mansfield, I'd like to say I have no problem with that. This hospital is being closed. That's the whole point. It's a change in the service provision, and that's why these people need this service. In terms of the fairness between mental health and physical health, you know, there are chronic physical health conditions, but as we were discussing just now, we understand that mental health conditions have a much longer term impact on families on the whole than many physical health conditions. So this is why this is a special case. And finally, yeah, as three of us have now said, we're simple councillors. I can't see what the problem is with a bus. In fact, I can see massive advantages to a bus in terms of community cohesion, environment, and all these things. A bus to Mansfield, a bus to Nottingham, to try and address this issue. You know, all these sorts of faffing about. This bus could presumably, as you said, serve many different cohorts of patients. Thank you.
Idris.
So if you provide a fixed service, and I think that was alluded to, as opposed to a flexible one, I can guarantee that that will be inappropriate for most patients. And that's what we were told during the engagement exercise. So I think we'd be in danger of saying, well, you've told us you want a flexible system. You don't want a set timetable where you can only go if you're available at that time on that day. And if they tell us that, and we go, but that's what we're going to give you. And I think, you know, sort of, I find that problematic. If you do an engagement exercise, my view is that you take on board what the public have told you. So that's what we're trying to do in terms of that flexible. So, and I know it means that therefore it looks a little bit more vague, and it's not a timetable or a specific facility. But I'm stuck between whether I satisfy the need for that simplicity or whether we try and meet the needs of what we've actually been told. Any sort of organisation. And in terms of providing an NHS service, which does go beyond our statutory duties, but we've said that we'll do that because of the circumstances, to do it in the most expensive way possible seems a very poor use of public money, to be honest. So again, you know, I come back to, we're trying to meet the needs of the public and the patients that have been expressed in a way that is the best use of public money. I think the issue about mental and physical health, we've accepted that it's a particular issue in terms of patients from Bassetlaw are used to a service and they will no longer get this service. So therefore we have agreed that there ought to be a travel plan, and that should include financial support, you know, sort of for people. But again, I reiterate, not in a way that actually makes them better off than they were before, particularly bearing in mind that 90% of the patients are not getting that. And we, you know, so we need to ensure a degree of equity, sort of when we're actually looking at these sorts of things, which is what we're trying to balance out.
Okay, now I think members of the committee have probably all asked the questions they'd like to ask. So we have the local member, Councillor Glyn Guilfoyle, who I'm sure will have some excellent suggestions as to how this travel package can be worked out.
I forgot one point I wish to make.
Fine.
Is that okay? Could I just come back?
Yeah.
Thank you. And it was just looking at Councillor Guilfoyle that reminded me. Mention was made about taxi firm, and again, I think that goes back to the commercial viability and whether it really would be in their interest to reduce the rates with such low numbers. But what we do have is a community transport service, which we already commission, and it is mentioned, sort of in the paper, and that is something that could be, sort of utilised. So that would be part of the package and the options. Obviously, not everybody would want that option. Some would prefer financial support to use their own car, so which is perfectly sensible. But that will be included in the plan.
Thank you. Councillor Guilfoyle.
Thank you, Chairman. I obviously do sympathise with some of the things that Idris says relating to the issue, but clearly also makes the point that it is the public of Bassetlaw and the patients of Bassetlaw that are more significantly impacted because of the closure of those wards, and will be impacted over the ensuing years. Clearly, also when we first talked about this, we were informed that the people from other areas had actually requested to go to Bassetlaw, and a number of them, rather than actually being directed there by the clinicians, they'd requested to go to Bassetlaw, or had requested not to go to the one that was nearest to them, but away. Having read that, my first impression was there were more sort of reasons within the report for not doing it than there were for doing it, or that was the way the report read to me. This was something that you really didn't want to be in the middle of. But having reflected on that initial read, I actually, contrary to the chairman, which I do actually agree with the travel plans being there available for people, whether that be explaining to them how do they get to the facility, what bus routes there are, what train routes, etc., etc. I believe that should be put forward for anybody anyway. That should be a norm for any facility. So I totally support that, especially as people know I don't drive. So, if I want to get there, at least I know there's a travel plan in place, or I can actually glean that information to enable myself to get there, come what may. So I support that. I see the dilemma about other services, but I go back to the point that the disadvantage that people are being put into. There are two buses, I think, Idris, that run from Bassetlaw District General currently. There is the paediatrician one, and that again, the public uproar that's not brought back yet, but there is the paediatrician one that runs. But there's also a general bus that if you're using other services, or even if you're visiting people at Doncaster, you can relieve yourself of a bus that leaves, and I can't remember whether it's hourly or half hour or whatever, from Bassetlaw Hospital direct to Doncaster. So there is, in one sense, there is a bus that is provided for people to get through to, not just for one service, but for all types of services that Doncaster have decided not to provide in Worksop, but provide alternatively at Doncaster. So a precedence in one set is set in that particular area, in my opinion. But I understand your dilemma about not, when it's in total 80 potential patients over a year, about the provision of a bus. I also understand the issue that you're talking about, where actually if you say it's only available Tuesday, Wednesdays off, that doesn't help people if they can only see their loved one at the weekend. And then, they're hit with the impact. So in one sense, the package as you've put it together, and I also understand the bit where you're saying, well, we're not going to literally sort of include the fact that getting from, say, Harworth to Bassett Law is at your own expense, but the rest of the way we will pay for. I understand the reasoning behind that. The issue for me is the length of the scheme. One of the things that you've talked about here, and we heard earlier, is about the investment that is going in to Bassett Law for the community mental health teams, and that in reality, ultimately, we all hope, will be successful in actually doing away for the need for people to actually be placed within care, in a care facility away from their home, but it can be managed locally. So I'm hoping that over that period of time, over that period of investment, and I think is over 4 years, the period of that over that period of 4 years, we will actually see a reduction in that number of, on average, of 80 to a lot less. I would hope to see at least a halved, where people do not need to have those services or access that type of service, but it is caught earlier, etc. It'll probably take longer, but I'm going on the sort of amount of time that you've put for that rolling out of the investment. So, you know, which I used to do, but I'm not here as a trade unionist anymore, but I used to do the negotiations with the people. You know, I would be looking initially, you'd want it in perpetuity. But I realise that in one sense is probably out of the reach. But what I would say as a bare minimum, what I would be saying is that it should be for the lifetime of that initial investment, where we could then see that service has reduced that number and is working. And we've all heard here today about another service, you know, unfortunately, that's going to miss, and that's going to miss over a number of years and took some time. And what I would want to see is that before we get to the end of that 4-year period, I would hope the Scrutiny Committee is doing what it's done so well today, which is scrutinising the changes that are going to be occurring in Bassett Law and elsewhere, but also and taking them to task. I would hope that at the end of that 4-year period, there will be no need for any additionality to be given to the Bassett Law residents, because actually they're getting the help that they need in their locality. But actually to cut it off after 2 years, in my opinion, would be wrong. And I think that my opinion would be that it should be for the lifetime of the amount of money that's been put in to improve the services, and that it's reviewed just before the end of that 4 years. And that a report came back here as well, explaining to members that over that period, this is what's happened, how many people have alleviated themselves of the service, and that actually, unfortunately, we've built a place in Mansfield with a large number of beds, but we don't need them anymore. Thank you, Chairman.
Idris.
Thank you, Councillor. So thank you for the support of the travel plan and your sort of very considered approach, you know, sort of to this, despite obviously the concerns about it. You mentioned about the Doncaster bus again, and obviously where you've got high volumes, and as you say, that's open to all the hospital services across sort of Doncaster and Bassett Law. So that they're probably dealing with more patients in a few days than we're talking about in a year, which is why it makes it a more viable approach in that circumstance, going to Doncaster Royal Infirmary. In terms of the length of the scheme, I suppose two things to bear in mind. One is it doesn't say it stops after 2 years, it says it will be reviewed. Secondly, there's a national consultation taking place at the moment that may set support to patients in a different way. That may or may not be less advantage. I don't know, but it says in the scheme that regardless of the results of that consultation, unless that offers a higher sort of financial support, we're committed to what's actually being put forward for at least 2 years. So that could be higher than what is available nationally for that period. Your point in terms of, well, where are we going to be in 2 years? We'll have to see. Hopefully, the investment that we're making will have the impacts that you're saying. We're actually in the second year of that 4-year investment, so hopefully we will see things, you know, sort of change before 4 years is up, because we're already partway through putting that investment in. I think the only other thing I just finish on in terms of the length of this type of support is, at what point do the residents of Nottingham and Rushcliffe and elsewhere sort of say, well, actually that's no longer a change because it happened years ago, and we now feel that, you know, sort of that there ought to be some parity. And I think they would probably have a point after a number of years, and I'm not putting a figure on that. The proposal is that that we commit to something for 2 years and we review it after that time. But I think there is an issue for residents elsewhere in the county that says it's one thing to accept that you've got a service currently in Bassetlaw and it's no longer going to be in Bassetlaw, but over what period of time is that really a disadvantage when everybody else in Nottinghamshire is still using the same service? I don't have a precise answer to that, but I think it's a valid point that people would probably raise.
Thank you, Idris. Does anybody else wish to speak on the matter? No. Well, members, we have to make a few decisions today. Can I ask you first, please, when you intend to move these patients to Sherwood Oaks or wherever?
So, assuming the move goes ahead and in the timescale envisaged, it will be the spring of next year.
The spring of next year. Okay. So there are two things I want to mention, really. The local member has mentioned he's not happy with the 2 years. And I can fully agree with that, because, you know, we've looked at something today that has faltered and not been picked up. And I wouldn't like this service to falter and not be picked up within that 2 year period. I think it should be a 4 year period. It gives everybody time to settle down, get used to it, and it's what the local member is actually requesting. But I need to ask members whether you are happy with what is a major move from Bassetlaw, taking their mental health facility away and taking them to Nottingham, Sherwood Oaks, Millbank, and possibly Highbury. So are members happy for those people who live in Bassetlaw to be taken away? At the end of the day, I don't think we can consider the people who are coming the other way, because the whole point is this facility is being taken away from Bassetlaw. If people in Nottinghamshire elsewhere decide to go to Bassetlaw, that is their choice. There is still a place to go in Nottingham, namely Highbury or Millbrook. The Bassetlaw people don't have that privilege. They don't have the opportunity to stay in Bassetlaw. They have to move. And this is the consideration, members. We have to make sure that this major move is in the interest of Bassetlaw residents. If you happen to live in Ashfield, as you've alluded to, they still have the choice to go to Millbrook or Sherwood Oaks or Highbury. Those people in Bassetlaw do not have that choice. They are being transferred, whether or not against their will, to a place away from where they live. That is the issue we've got to decide. Do we think that is in the benefit of Bassetlaw residents? Now, we've heard that it's going to open in the spring. We've heard that there's, in my opinion, a very wishy-washy travel plan. It's not a definite travel plan. It certainly is only for 2 years, not for 4. But the main issue is that the hospital is closing 2 mental health patients with no crash beds available, so that somebody who's got a problem probably for 24 hours has got to come to somewhere over here in Nottingham or Mansfield. Is that, ask yourselves, in the best interest of the patients in Bassetlaw? Councillor Lee, you just wanted to come back.
It's a difficult one, isn't it? We all know that in certain circumstances in mental health, it's always better to be in close to your friends and family who can support you. And if we're saying that friends and family may not be able to visit, then I would have major concerns on that. So I think I'm agreeing with what you're alluding to.
Councillor Guilfoyle.
And if you ask me that question, Chairman, I would say exactly the same as you. I don't agree with the move, full stop. And I know there was a position of 2,500 people who were totally against the move. The problem is that, the feeling I've got from, the people is that is, well, we know it's a decision to make because they're already building the facility. That the problem, that's what we've
Well, that's
we've
putting
got.
the cart before the horse, isn't
Well,
it?
exactly. They've built, but they have, they also, we know, because we've been to see the facility that's existing.
I know, Idris, you referred to only 80 patients a year, but they are not necessarily short-term patients. They could be long-term patients. So the carer may want to go every day of the week. They may. I think this is an extremely difficult decision. Councillor Welsh.
Yeah, I'd just like to add as well about the facts speak for themselves. We've had a previous presentation about mental health crisis. We don't have to look very far in newspapers, in medical journals about the impact in mental health crisis, the rise in mental health crisis across the country. Everybody in NHS Health Trusts are predicting a rise in needs with regards to mental health. Not only a rise in need, but a huge backlog. We're talking about 80 people. I mean, my issue with this at the moment is we're in a very precarious position with regards to mental health. Too many people are already falling on the wayside with regards to this. So my concern is it's 80 at this moment. It's hard to predict how much it's going to be in a year's time or even 6 months' time. Who knows when we've got another bleak winter perhaps ahead of us and how that might actually affect people. So my concern is making this decision at this time, I think, is not a good decision at all. But if we are saying that we want them to be in Bassetlaw, it certainly has to be an improvement on the situation that people were having to put up with in Bassetlaw prior to that, because quite frankly, the report on that was not very good at all. So high quality mental health support is definitely needed. I'm a firm believer in local health services that are community based. That's what I fundamentally believe in, that you recover better when you are around your families and friends and you are in that makes you feel securer. For the majority of the time, there are the odd cases, but yes, a firm believer in health services that are community based, and sometimes I think places like Bassetlaw are too easy to take services away from people. They think that people perhaps aren't going to kick up a fuss or it doesn't really matter, but for me it should be staying there in Bassetlaw.
Councillor Martin, I'm just coming back to you for the last word.
Well, I think they've taken the decision to move the acute mental health services, where people have to be staying for quite a long time, more central in the county for the benefit of other residents across the county. That's their approach. The other mental health services are still remaining at Bassetlaw Hospital.
Yes.
That's if I'm reading that right. And it's actually not the patients themselves that will have any inkling of the geographical distance. It's the relatives that's coming and the carers that's coming to them that are going to be impacted greatly by the travel. The travel package is very, very diverse because some people will want to come in their own car. Some people will want to come, by a taxi or whatever. But I think the real issue is sort of they're trying to vastly improve the services for acute care, and they can't do it in Bassetlaw. That's what they said at the presentation. That's what they're spending a lot of money in Sherwood Oaks, and also as well that increases the older age people's mental capacity at Millbrook. So it's a double whammy, really. I know Bassetlaw, they're moving it from Bassetlaw, they're already intending to move it from Bassetlaw. So I don't think that's really up for debate for us now, because that path is set. You know, we're talking about the travel package and how we deal with the people, how they get from Bassetlaw to this.
I agree with you, but they have put the Bassetlaw residents, be it carers or relatives, in a situation where they have to go out of Bassetlaw, whether they like it or not. If they don't have a car, they haven't got a facility except taking a bus timetable and catching a bus. And that is going to be an all-day operation for anybody visiting somebody across in the other part of the county. So we are where we are, members. We have to make a decision on whether or not we feel this move is in the best interest of Bassetlaw residents. And I'm going to ask for a show of hands. Can I have anybody who feels this is in the best interest of Bassetlaw residents? A show of hands. There is no support at all for this. Am I right? I'm correct? Idris, we are in a very difficult situation because we have asked that you tried to find somewhere local, be it only a small property where people could at least be for 48 hours while they have a calming down session. I don't know what happens with mental health, but I assume that if somebody gets into trouble, they need time to just calm down, and to be taken from Bassetlaw to Millbrook or Sherwood Oaks, miles away from your family. I think this committee feel that that is not in the interests of the Bassetlaw residents. I realise your board are meeting in about a week's time and they will make their decision. And if they decide to move, which they obviously are going to probably do, it will be without the support of this Health Scrutiny Committee. And we can see what does happen. And I would ask that if you go against our wishes, you make it very clear to the board that we haven't supported the proposal because we don't think it's in the best interest of Bassetlaw residents, and that we would like you back. We're talking about 6 months. We would like you back if you go ahead with this proposal and you don't look for another property that would just see people on a crash bed situation at least. We'd like you back in 6 months, please, to come and report about, if you've done it, your move to Sherwood Oaks, if you're using Millbrook, what the effects have been, how the transport's working, and bring us up to date. But I'm afraid you will have to take it back to the board that you don't have our support.
I'll certainly take the message back, Chair. In terms of 6 months, yeah, absolutely. We can have somebody come back to the committee and inform them about the usage of course, in 6 months, no move will have taken place, probably. So
well, if you're just moving at that time, obviously there's Martin will liaise with you, yeah, and we will go for another 2 months. Yeah, but it is essential that we see, if you decide to move, what actually has happened.
Yes, so a few months after the move, and then we can bring an update. And just to note,
Councillor Martin wants another quick word. We're virtually closed, but
yeah, thank you, Chair. Do they not provide any of those services at Doncaster or Sheffield University hospitals?
It's not a district hospital or hospital service. You know, this is a service run by Notts Healthcare that happens to be in a hospital. So I think there's a misconception that this is a service for overnight patients because they're in a crisis, because it isn't. The length of stay is about 28 days on average. It's a different service, and it's not a hospital-based service. It's a specialist mental health inpatient service. So they're different. And it won't be Bassetlaw CCG, of course, that will come back to discuss this with the Health Scrutiny Committee, because we're likely to have been disbanded on the 1st of April.
Yes.
So it'll probably be somebody
else. I'm not just for clarity, I'm not saying that we're asking for a place in Bassetlaw for long-term patients. I'm talking about, I mean, I don't know what happens, but if somebody has a problem and they're unstable, let's put it that way, and just need a 48-hour cool down period, it would have been nice to have seen that there were some beds that people could just be put in, not necessarily mentally ill, just a little bit over the top with stress, it would have been nice to have known that there was somewhere. And that's what we were asking for. And that's what Councillor Guilfoyle and I asked for when we went for a visit, that there was a place where people could go for a cooling down period. Not really mental health, more if somebody's had a stress relationship or something and they're really very stressed, rather than bring them across here. It would have been nice to have known that they could have just stayed in Bassett Law for a couple of nights, calmed down, the relatives could have gone and seen them, and back home they would have gone. But this is a major, major thing to keep moving people about. But, you know, you will make your decision in a week's time. Sadly, you won't have our support. I hope if you take it ahead that you are successful, and in order that we know, so we don't get into a situation where it's all happening and we have no idea what's happening, we'll have you back in circa 6 months, in which case you can bring us up to date. And thank you for coming, Idris, and thank you for having the patience to wait for us. I'm sorry we were so late. Thank you. Members, we have a, yes.
Chair, just a quick one then. I mean, obviously the gentleman's coming back in 6 months. Are we saying then that we're happy with the travel plan?
No.
No, that's also, yeah.
We are
so that
not
was part
happy.
of the vote as well,
no,
yeah.
we are not
No,
happy
well, I know
with
we're not
the
happy,
travel
yeah.
plan.
Yeah.
So we'll see what happens in 6 months. Okay. Members, thank you very much for attending today. We've had rather a long committee. We're supposed to be looking at the work package, work ahead or timetable. I think my Vice Chairman and myself and Matt need to look at this. Thank you, Idris, because next month we have GP access. My goodness me. We don't necessarily want to be sitting here at this time next month. And I think we might have to cut something out. I'm not quite sure what. Might draw some straws. But we will have a look at it, Martin and Matt, and we will see how we can do this, because these committees are extremely long. Thank you to the 2 substitutes who came in. I hope it hasn't put you off health scrutiny forever. And thank you to you all. And Stuart, please could we have the live link switched off now? Thank you. Thank you to everybody. Safe journey home.